Okay, well, my clock says 4 o'clock, so thank you. I'm going to go ahead and get started on time, and I'd like to welcome all of you. Thank you for attending and being dedicated to you and your patients in your orthodontic career. And after almost 50 years, I'm still here doing doing this work. Let me turn up my light a little bit. There we go. So you can see me. And nice to see some of you here that I know. And I am especially happy to be presenting this topic. This topic is going to be impressive, I think, when you see what is going to be a part here. So, okay, so let me say that this is going to be way more than you expected if you were reading the promotion of it, saying, "Oh, we're going to do a couple of case presentations, case reviews." Oh no, this goes way beyond that. So this is going to lay out a whole new set of protocols for you to use in aligners, and in particular using it in the mixed dentition. So let me, how come it's not going here? There we go. Okay, wake up. That was my computer, I think. So let me first start out and say, you better have some note-taking capability, and maybe even your phone to take a couple of pictures as you go along here, because there's going to be a lot of new material. And let me get my screen a little bit better here. Okay, so before I get into this, let me say that if you prefer continuing to use lower lingual arches, utility arches, advancing arches, alignment arches, even headgear and things like that will be made easier for you in the opportunities you're going to have in your future mixed dentition cases. And but you're welcome to continue using those and making a decision on a patient-by-patient basis. Now, as part of an intro, let me say that progressive aligners and aligners in general have been considered an adult type of an appliance. The patients coming in saying, "I want Invisalign," or very few say, "I want aligners." They're saying, "I want something besides brackets to straighten my teeth. I want straight teeth, and I want it done without braces." Okay? So that is a typical and a very common adult request. Now, when we move into the children, which one in particular, moved into that area through teen, things like that. I'm going even earlier than that. I'm going all the way back to where, 8 years old and even earlier in this new system that you're going to do. Okay, so you're welcome to ask questions during this. It's best if you do it by chat. And on my second account here, my other computer, I've got the chat visible. I may not be looking at it directly or immediately, but that's how you ask a question. Or you can interrupt by unmuting yourself and then later being sure that you mute yourself. Okay, so the old system remains of utility arches, lower lingual arches, advancing arches, that sort of thing. That all remains, okay? But you're going to see differences if you have an aligner to use. Now, in the unlimited progressive aligners, it has a 5-year warranty period. Now, what that means is that for 5 years, chronologically, from the time that you approve and pay for the case, that you have a 5-year time where you can order additional aligners with the same endpoint in mind. In other words, you can't say, well, now I want to change to extraction, or now I want to change to, we don't want to move those that far forward. No. They come up with a concept, and as long as you're following that concept for 5 years, well, you can keep going. Now, I don't think there's going to be arguments, even if you want to change. But chances are, if you change, let's say at the start of phase 2, to using brackets with an extraction case, well, then you're not going to use the aligners again unless you use them to finish. Okay, or you may you may go from aligners to brackets back to aligners. Okay, the two systems of IP appliance brackets and arch wires and progressive aligners are going to be are integrated together, working together, so you can choose the best one for the patient and the best one for you. Okay, let me explain that concept. The adult patient may come in and say, I want to have my teeth straightened without braces. But what child says that? I mean, I remember a few children that we used some ceramic brackets on because they were in the film industry. Okay, but other than that, come on. The children don't care, and in fact, the parents prefer brackets on their children if they are going to, because then they don't have to worry about them wearing it. They don't have to worry about it falling off and them losing it, that sort of thing, okay? Now, in the mixed dentition, the way that I'm going to present it, the thinking goes that the treating doctor prefers aligners. That's right. We're going to assume that the patient's not asking for aligners at this young age. It's the treating doctor that prefers to use aligners because it's easier for them technically. It's easier chair side. You don't have the brackets falling off. You don't have to size bands and fit bands on a young patient. And you can even eliminate a lot of other appliances like TPAs and even rapid palatal expanders, although that's different with an aligner or used for expansion. But if you like using all those things, continue doing it and keep that in your tool chest, because some patients you'll say, I want to use these appliances for you personally and the job that I have in front of me. Now, the overall concept here in POS is to get the best end results for all of your patients so you enjoy and love orthodontics. And you have a successful career with lots of smiles, not only on your patients, but on you. And you're the one that is going to benefit in the long term on this. So we need to make some adaptations if we're going to use aligners on the young patient. And I don't know another company that has done this. Okay, they've all focused on selling plastic and selling plastic for for cases where they have all their teeth in place and they're just straightening the teeth. So hold on to your seat. It's going to be interesting. Okay, so all of these cases are going to be unlimited. Unlimited allows you freedom to start earlier and go year by year on your setups, making changes along the way, and at the same time making it quite easy chairside, where you just hand them a plastic tray and say, wear it, and I'm even changing the wear times for you, okay, the standard wear times. So this is in our already existing mixed dentition diagnosis system, we do a preliminary diagnosis. We admit we don't know everything in the future for you. You don't know the size of the teeth. We don't know how you're going to grow. We don't know how you're going to comply with certain things that you have to do that we're not doing. So this is a preliminary diagnosis to start in the mixed dentition with the opportunity to change our minds at the start of phase 2 based on the results of phase 1. Okay? That stays. We are going to use preliminary diagnosis concept on these cases, but only accepting for what I'm going to show you here, the non-extraction preliminary diagnosis. Okay, if it's a bicuspid extraction preliminary diagnosis, chances are we're going to say, okay, this is going to be brackets. Okay, we're using brackets because we don't want to deal with all the unwanted tooth movements associated with an aligner that's very flexible in closing extraction spaces and that sort of thing. Although upper 7 extraction, we're going to prefer aligners, okay? Let me just say that. So bicuspid extraction preliminary diagnosis is going to be reserved for us, where we have the most torque control, the most control over anchorage, closing the extraction space in a variety of ways with our coils and everything else. We're going to keep that off to the side for the bicuspid extraction case. So we have unlimited stages, but in this system, we're not going to ask to take it all the way to the end. We're going to say, give us 1 year of aligners. No more. Don't give us more. We only want 1 year. And then you're going to say, give me another year. And then you're going to say, well, give me a retainer. No, wait a minute, careful. Don't say, give me a retainer, because you see on this, it says 1 set of retainers. Okay, so be careful the word retainer. Okay? Because that closes down the case. So let's see. Hold on here. I'm supposed to get let's see, Control Pen. That's what it is. Control P. All right. So 1 set of retainers. All right. So the retainers are set for the end of the case. When you say, I want retainers are going to be a thicker material, more resistant, and there won't be any attachments on the teeth when you ask for retainers at the end of the case. Now, in unlimited, it's also been promised that we can reopen a case if they don't wear their retainers, and we want more aligners. Up to 5 years, we can still reopen the case, and we can get some more aligners. I have not got an answer yet whether or not you'd have to pay for the second set of retainers. Okay, so let's all understand that there are some words here that we have to be careful with when we are doing these long-term, cases, and I'm going to call them pauses and retainers. Okay, they're technically aligners, not retainers. Don't use retainers until the end, okay? And there may be some of the pauses that in between a series of aligners that that you're going to maybe remove all the plastic. Don't give them any plastic. Let the bite just settle. Okay. There's no obligation here to give them a retainer. If some little rotation goes back a little bit, it's okay. We could get it on the next set. All right. It's okay. Now we're going to be using then like preliminary diagnosis. All of your patients are growing at this segment of the population. They're all growing. So I'm going to show you how I am managing growth and the changes in the bite that may be related to growth. We don't know here until we get back some of the like predictive capabilities that we previously had. But I've got enough experience with that. Now, starting cases is going to be much more flexible than it was with brackets, okay? And I will explain that as I go on. We're going to work a little longer on some of the resistant issues that we see in phase 2. And part of the reason that we started cases early with brackets, utility arches, everything else had to do with some of those areas that were resistant. What are those? Class 2, deep bite, those types of things that in just a 2-year period with a set of brackets, we didn't always get everything fixed the way we wanted to, okay? So on those types of issues, we want to start earlier. And so a lot of the corrections are made before we get to phase 2, and we are overall more successful, more happy in our orthodontic career, and proud of our work. Okay, so now we're going to do year-by-year planning in the mixed dentition. That's going to allow you to organize your thoughts. Well, this is where we are, and this is where we are, and now we're on the next year, and now we're going to start phase 2. Okay, so it has to be organized. Otherwise, you're just randomly throwing things at the patient, hoping that you're going in the right direction. Okay, then we're going to have specific setups for the mixed dentition. And that's going to relate to growth, eruption patterns, space management, creating space that's been lost, all that sort of thing. Okay, now listen to this one. Tray management. Oh my gosh. Children can lose their trays at school. They take them out to eat at lunch in the cafeteria, and they end up walking away without their trays. Anybody that has children understands this as part of the way and part of the frustration that parents have. I am personally changing this system to a nighttime wear only for patients under the age of 10 years old. Okay? Now, and maybe even 11. It's up to you to make that decision. But I want nighttime only wear, and I will explain why I think we can do this nighttime only wear for our young patients. Okay? And that means tray changes maybe once a month. You wait a minute. We're in a hurry here to get through the trays. No, we're not. We want to go nighttime wear, change the trays once a month or maybe twice a month, but we don't want to burn through the trays and then have nothing to do. And now we have to go through another set of trays. So it's going to go, well, okay, the standard is going to be 25 or 26 trays every segment, okay? And you're going to have unlimited 5 years. That means you pretty much need a scanner because you can't be taking impressions and all that sort of stuff. So you have a scanner, and once a year, you're going to give your patient another set of trays. Some of those will be aligners. Some of them will be, in our idea, they may be a retainer, but we don't want to call it that. Okay. Or they may be bonded wires or even no retention. Are you interested? I'm sorry if I've confused you so far, but keep your mind open here. Let's go through. Wait a minute. Let's make sure we got unlimited trays, warranty 5 years. Refinements is unlimited. In other words, we can make as many refinements as we want with this package. Okay? All right. So kids and parents do not care if it's aligners or brackets. They trust you. You're supposed to be the one that decides which is best for each patient. If you give them aligners as best for that patient, well, we don't want them losing the trays at school. We would like them wearing them at night if possible, so they put it next to their toothbrush. After they brush their teeth, before going to bed, they pop these trays in. We usually will not have class 2 elastics. We will not be doing IPR on these patients. So they have some trays that they change in their mouth. And then on a schedule set by you, on nighttime wear, we're going to change their tray, okay? Some tooth movements are better with aligners, and you're the one that's going to decide if your particular patient has those characteristics that you think are going to be better treated with aligners. Chances are, if you start with aligners, you're going to do phase 2 and finish with aligners. Chances are. If you, with the option, of course, to change to brackets if they don't comply. Okay? Now, some tooth movements in the mixed dentition, you have an advantage. Distalization and molar rotation of upper 6s without the 7s in place. Okay? The 7s haven't erupted yet. Now you have a unique opportunity. Now, upper 7s generally do not impact. Let's say that you distalize too much and you made too little space for the upper 7s to erupt. The upper 8s are there. You know what happens to them? They erupt to the buccal. That's what happens to upper 7s when they don't have enough space to erupt. They erupt to the buccal. So you're welcome in the upper arch to like manipulate those upper 6s. Okay, now that's not going to change a skeletal class 2, but it will change a dental class 2 through just manipulating and changing the same trays that you otherwise would be using for just straightening teeth, or maybe fixing deep bite, or maybe expansion. Expansion, yes. Expansion of the dental arches, and I'm talking about not just the first molars. I'm talking about the first molars, the primary molars, the primary canines, everything. Okay? We're going to put attachments on those, and we're going to widen them slowly. Okay? Now, if a patient is losing tracking on a nighttime only wear, then you might say, let's wear them full time on weekends and then nighttime on school days. Okay? Don't take them to school. If they're still losing tracking, then we say, okay, for you, it's going to have to be all day, every day, just like an adult patient. Okay, so we're going to start out with the nighttime wear. We're going to build on that. Where on the adults, we start out saying, well, let's change it every 2 weeks, or when it stops being tight, when you put it back in, and you're still, now all the teeth are in the case. Can I change the next tray? Yes. So you then shrink down how fast the trays, because you want to get done quickly. On the early mixed dentition case, you don't want to get done quickly. Take your time. It's okay. And if you don't get every last little thing, like all the distalization that you wanted, well, that's okay. We got another chance. Here's another set of trays. On these, as you get older, okay, I want you to start wearing them, full time, or change them every 2 weeks instead of every month. Do you understand? So there's some flexibility here, and I'm going to tell you how to determine when to do that. Okay. So distalization is definitely better on upper sixes. Lower sixes, we can do something with. We can tip back the lower molars or even distalize them a little bit, but there is a risk of lower 7 impaction if you do too much. So we can control the lower as well as upper molars easily, even though it's pretty much in the specialty. Lower molar distalization, they say absolutely don't do it. Stop. Change that setup. Amit, every time he sees lower molar distalization, he freaks out. Okay, he says, no, stop that. None of that. Okay, everybody knows you can't do that. Okay, well, I'm saying, well, if you start early, we may have some opportunities here that we could even do a little bit of lower molar like distalization or tip back, which are actually different. Distalization would imply a bodily movement. Tip back would be just tip back the crown a little bit to upright it. Okay, posterior cross bites. We can expand the upper. We can constrict the lower with aligners very easily. We can't do that so easily with our brackets, but we can. But it is a dental alveolar expansion. Now, we do dental alveolar expansion and constriction in adult patients, and we do if we are on, let's say, like a teenage patient, we do it with arch wires, or an adult patient, older patient, we do it with arch wires, our dental alveolar expansion or constriction of the lower, non-coordinated arch wires. We choose a non-extraction number 2 upper, and then we choose a medium ovoid lower, right? We try to constrict the lower, expand the upper. If it's more aggressive, then we use a lower lingual arch on the lower to constrict and then expand the upper. Okay, it's a lot of work. We can do it though. But all we do is the same tray. You just give them a tray and say, okay, wear these trays. As long as you can get them to wear the trays, we can program into it an expansion of the upper, including the primary molars and canines. Upper cuspids, we have a rule. You cannot start a case with brackets. You can't put a bracket on upper laterals. You can start a case, but you can't put a bracket on upper laterals until the canine is safely erupted down the root of the lateral of the of your lateral incisor. We all know this, right? Because we say, okay, and I show you one case where we melted the root of the lateral incisor, or maybe it impacted the upper canine, and all of a sudden everybody goes, oh no, we aren't doing that. And so that has been drilled into your head. Okay, well now let me back that off a little bit. If you're using aligners, we have control over this, and I'll show you how to do that. Advancing lower incisors to reestablish space, mainly they lost one or both of the primary lower canines, and now you're using advancing arches trying to push those incisors forward to recreate that space that was lost. Now, all you have to say is, I want a 7 millimeter bubble for in the place of 8.3, the lower canine, and get them to wear the trays. Now, is that easier? Because before, you have to use an advancing arch followed by a lower lingual arch retainer. And now you have large wire spans that are flexible and flopping around and breaking and falling out of the tubes. And so there's another way of doing this now. So advancing lower incisors to establish or reestablish spaces. Longer treatment, more trays needed for intrusion, deep bite cases. We know that intrusion of teeth is not always the easiest to do. How do we know that? Well, because the teeth are resistant to biting forces, and you're biting on them, and they're not intruding. Okay, it's simple. So when we start applying forces, it's going to be a slower process to level by the method of intrusion, as no matter what appliance you're using. Utility arch, sometimes we say, oh, you see those incisors intruded? And then I show you overlays that show that no, the molars extruded. And that's what you were looking, and you assumed it was the incisors intruded because you saw the bite opening. Well, we can extrude molars. We can intrude incisors with an aligner also. Okay? We just have to make the diagnosis and give the direction. So let's start with anterior-posterior classification in the mixed dentition. And I see some confusion of this as I get consulting cases, and I want to clarify it right now. And we have to determine if the case is class 1, 2, or 3 dental, class 1, 2, or 3 skeletal, and then we take into consideration E-space shifts, eruption patterns, change in the bite due to growth, and we put all those things together, and we're hoping at the end we're going to have a class 1 bite. Okay, so let's start off here. I've got tooth numbers. Some of them are permanent teeth, right? 1, 6 there. Some of them are primary teeth. Upper right is 5. Upper left is 6 with the tooth number underneath. If you're not using this, get used to it. 7.5 would be lower left. 8.5 would be lower right. Okay? So we got our primary molars, primary canine, permanent teeth have 1, 2, 3, 4 in front of the 1, 2, 3, 4, 5, 6, 7, 8, right? So we have our permanent teeth, our unerupted permanent tooth, which doesn't have enough space here. And then we have the primary molars and permanent molars. Everybody with me? Don't answer. This is webinar. Don't everybody answer at once. Okay, so I'm going to have you draw some lines here. Now, if we were drawing lines in the permanent dentition, we would draw a line on the mesial buccal cusp, and that mesial buccal cusp should fit into the buccal groove of the lower molar. So we'd call that class 1. It would look like this over here. This would be a permanent class 1 molar relationship, okay? In the primary dentition, this is class 1 molar, permanent molar. It looks like a 4 millimeter class 2, okay? How does it change from the 4 millimeter class 2 to the end point of a class 1 molar, the way that we look in the permanent dentition? It's a combination of the lower molar shifting forward and growth, okay? Now, these yellow lines are what's called terminal plane. And if I draw a line on the back side of the E, or the 5-5, and the 8-5, the E on the lower, they should line up as a terminal plane to be class 1 primary molar. Same thing on the 5-4 and 8-4, same thing. But this one is perfectly right on this one. On the upper, on the E's, is a little bit of a class 2, and we're going to actually do that. Okay, hold on to your seats. The next step is going to be automated simulations. And I'm going to refer to that because we're only 3 months away now. January 20th, it's been confirmed as being released, okay? Automated simulations. I'm going to be doing a 2-day seminar live in California, and I'm going to show you the whole. It's gonna make your mouth drop. Okay. So, for starters, there's going to be an occlusal table. The occlusal table is going to be drawn here for you, and you just have to place a couple points, and then you're gonna manipulate these lines, vertical lines, forward or back, and this is going to measure class 1, 2, or 3 for you. In the mixed dentition, I want you to place your lines on the terminal plane. You're only going to have one line upper and one line lower. And I want you to place those on the terminal plane. If they are not there, you can always place them on the canine if you want. On the permanent dentition cases, I'm going to ask you to place those vertical lines on just as I have here. So this would be a class 2 molar if it was permanent dentition, and a class 1 molar, you would place the line on the primary teeth. Am I confusing you? Okay, don't worry about it. It's coming. At that seminar, we'll explain it. We'll show you on a whole bunch of cases where do you place the line. But I want you to get used to these vertical lines because you're going to be placing those. So in the mixed dentition, in automated, if you see mixed dentition, you're going to be placing these vertical lines. You'll have a choice to place them on the sixes. I'm sorry, on the distal of the permanent, on the distal of the primary molar 6474, or on the distal of 6575. Take your pick. It's up to you where you want to place it. But let's just say this is a class 3 case coming in the future. Okay? This is a class 1 case at the moment. So, if in this set of cases, you can see I have a class 2 looking primary molar. You're welcome to apply the vertical lines there. Whoops. Sorry, I didn't do it right. Oh my gosh. Okay. You see how confusing it can be? Don't do this. Okay, so this is class 2, but you can do the same thing at the molar. So you're going to be placing this line and this line. And then it's going to calculate how much class 2 you have automatically once you place the line. You can do it anywhere up and down the arch here, okay? Now, class 1 from the palatal becomes important, especially, well, it's important in all dentition, in all class 2 cases especially, but especially when you are diagnosing in the mixed dentition. Now, the permanent first molar from the lingual seen on a scan, you've got the mesial palatal root. That's supposed to go into the central fossa of the lower permanent first molar to be class 1. So this is a class 2 from a lingual, confirming the class 2 on the buccal, confirmed by anterior overjet consistent with class 2. Okay? So everything is class 2. We have a width of a +4. Let me go through that again. Just a minute. I'm changing to widths in automated. And you'll see, instead of A and B, we're not even going to look at A and B. We're going to look at widths. Width is a +4. To be class 1 width is 0 plus or minus 1 millimeter. So when it says +4, that's a skeletal class 2. A point is in front of B point at the occlusal table or occlusal plane in 2D, occlusal table in 3D, by 4 millimeters. A point's in front of B point. That's a skeletal class 2 by about 3 millimeters, okay? The upper jaw more forward than the lower jaw, either due to the upper jaw being protruded or the lower jaw being bent, okay? So we have dental class 2, skeletal class 2 in the mixed dentition. All right, let's look at an 8-year-old girl. There's a hand up. Oh, okay. Go ahead, Dr. Hisham, our VIP.
So, Dr. McGann, I want to clarify in that last one, you mean that the palatal cusp of the upper first molar, it should be in the groove of the lower in the mixed or in the permanent dentition?
Both. I'm looking at
both for it to be class.
I'm looking at the permanent molar here, the 6s, right? So this is a class 2 by this amount right here, because this arrow, this cusp is supposed to be in the center of the in the central fossa of the lower first molar. The mesial buccal cusp is supposed to be right there, or the mesial palatal, and then the distal palatal cusp is supposed to be on the marginal ridge of the lower, from the lingual. So I'm defining class 1, 2, and 3 from the buccal and from the lingual, and you'll see why in a minute. Okay?
Thank you, Dr. McGann. That's perfect.
Did that explain it to you or not? Don't worry. We'll do more.
It's crystal clear.
We'll do more cases, and then you'll see. Okay. So here's another case. We have a mixed dentition case, obviously. And I have an occlusal table here that you're going to determine. And then we're going to position this vertical plane. Since it's mixed dentition, we're going to position it on the distal of the primary molar. And that's going to show you a class 2 from the buccal. Now we are next going to look on the lingual to see where the palatal cusp is, because that changes according to the molar rotation of the upper. So if the upper molar is rotated mesial palatal, from the buccal it looks like it's class 2, but from the palatal it's class 1. That is a favorable case. Okay, that's a favorable case. So I see some mesial rotation of the upper molar. Do you see that? There's a little mesial, it's not a lot, maybe 10 degrees, but that 10 degrees can be very important. I'm going to show that to you in a minute. And then we have a deep bite, and I have drawn lines here. You can see that we have a posterior occlusal plane, and then we have an anterior occlusal plane. The posterior occlusal plane would actually be lower than this. We go from this distal buccal cusp here, right there. That would be the line. But from the anterior, I'm drawing it from canine to canine, and I can see that the lower incisors are extruded, the upper incisors are extruded relative to this flat plane that we would put anterior and posterior. Okay? So this is just evaluating a case now. E-space, let's talk about E-space. I said that it changes from this 4 millimeter class 2 look on the buccal to class 1, partially due to E-space. So we need to know what E-space is about. We need to know how to manage that in aligners, and we've been doing it with a lower lingual arch, and we may still do it with a lower lingual arch, okay? So primary molars are larger than permanent bicuspids, and during the time between the loss of the lower E's, that's a 7.5, 8.5. Between the loss of the E's and the full eruption of fives, there is drifting. The upper sixes rotate mesial palatal because they got three roots. They rotate around the palatal root. And that's one of the things that then sets up a whole class 2 case. We want to catch that before it happens if we can. The lower shifts forward. The molar shifts forward. So you're used to seeing this, right? So I've got a case here. I have a 3.5. That's a permanent 5. I have an 8.5. That is a primary molar. And I have shown you how much bigger, just by making a screenshot of 3.5, labeling it 4.5, how much bigger the E or 8.5 is than the eventual 4.5 that's going to come in. Okay? You got that? So we have excess space there. And in the time that the primary molar falls out, without the lower lingual arch in there, the molar will move forward, will shift forward, changing a portion of that 4 millimeter class 2 permanent molar to a class 1. Like that. So I call that the E-space shift. In some cases, we want that. In other cases, we don't want that. Okay? If you were going to put an aligner on top of this right now, instead of the lower lingual arch, you decide you wanted to put an aligner. So you didn't have to fit the bands. You didn't have to do the lingual bar. You didn't have to deal with it breaking or anything else, okay? And you decide that you wanted to put an aligner over this right now, okay? With the idea that you're not going to pay $1,000 for a set of aligners just for this. No, you're going to get an unlimited package that's going to take you through phase 1, phase 2, all the way to the end, okay? You're not going to do this case with brackets. You're going to do it with aligners, okay? So you decide, I prefer doing that, boom. What you're going to get is, you're going to ask for an eruption bubble where this space is. You're going to say, I don't want, or I do want, either way. I want the molar to shift forward or not. And if you make an aligner over this primary molar, well, you've already got a bubble. There's a bubble there right now. If that tooth falls out, you have a void representing that tooth that was previously there. Okay? You get that? So in the instructions of the aligner, they can program it either way you want. You just have to tell them the way you want it. Eruption sequence. Let's talk about that. I have to go through some of the basic mixed dentition stuff. I don't want to bore you here, but you need to know for sure, and everybody needs to know what I'm talking about before I start saying what we're going to do, how we're going to manipulate these aligners. Now, the upper E's determine the location of the sixes. So wherever the upper E's are, the second primary molar, that's the upper six is going to erupt right next to it, okay? The upper sixes determine the location of the fives and sevens. The lower sixes determine the position of the fives and sixes, and you can change the position of the upper sixes to your advantage in the mixed dentition. Okay, so let's do this. So here's all of our permanent teeth, our other, see, I have to turn this off, hold on. Okay, so we have a sequence of tooth eruption. First of all, let's back it up a little bit. Lower sixes come in, and they are guided by the lower E. Upper six comes in, guided by the upper E. So primary tooth, class 1 is terminal plane. That's where that comes from. Okay? So then this comes in. This is now class 1. All right? Now this one falls out. This shifts forward. This comes up. And if you hold that molar back, it comes up and then drifts back. The 5 does. Okay? Goes up and then drifts back if you use the lower lingual arch. Or it will automatically shift forward. The 5 comes straight up, does not go back. And then a little bit of growth, and you get yourself a nice class 1. Okay? You got that? Then the lower 7 comes in. It pushes forward a little on the 6. That may also contribute to you getting a class 1. Okay, it is the eruption of the 7. Same thing with the upper 7 comes in. Now, if you take out the upper 6, the upper E, then the 6 will rotate, but it doesn't shift forward, it rotates. Okay? So we don't have an E space shift on the upper.
1 second.
Okay, the upper 5 erupts to the distal. So if you have a class 2 case and you reposition this molar, the upper 5 erupts into class 1. Okay? So the upper 6 determines where the 7 and where the 5s go to. We can manipulate that with an aligner in the mixed dentition. Okay. Now, in the eruption sequence, let's get this in here. These are the last teeth out. These are the last teeth out. Usually, the first teeth out are these here. The 4s come in. Then the 3s come in, and either the 3 and the 5s, it's about 50-50 which comes in first, 3s or 5s. And there's no big significance of like which one that I know of, okay? So then the 3s and the 5s come in, and that's why you get upper 3s blocked out all the time. The upper 3s get blocked out laterally. They're the last one coming in. And if there's not enough space, well, they get in trouble. Now, in the anterior, what you're looking for is any overlap of the 2 and the 3. Now, the upper canine will come down the root of the 2, closing any space from the incisors. As it erupts down the lateral root, it'll close the spaces if they're there. But what you're looking for, if there's an overlap, on the panoramic, you need to take your finger and see if you can palpate if there's a canine on the buccal surface. If there's not a bump there, it's on the palatal, and we got a problem. If there's a bump there, it will likely come in. It'll just come in laterally. The upper 3 will. Okay, so you have to be consideration of this overlap on the upper canine versus lateral. Are there any questions with that?
Yes.
Okay, there had to be. Otherwise, you're all asleep.
when you mentioned the lower E exfoliates and the lower 6 shifts forward, and then you have a little bit of growth to produce class 1, what happens? What about the drifting of the upper arch? The drifting.
The upper arch, the upper molar. Hi, Ben. Nice to see you. Okay. Pediatric dentist Ben Villalone, POS instructor. Okay, so you're asking what's happening with the drift of the upper molar. Okay. Now, the upper molar I mentioned rotates. I can't rotate that here in this direction, but it rotates mesial palatal. Like I just showed you on this slide. There's another one coming up. I'll show you when it's coming up here. There is a molar rotation, right? Now, you can stop that molar rotation if you want, or you could even rotate it more if you even further distal if you want. Okay, so you have options to like manipulate that upper molar. So, but you're saying without any treatment, this is going to rotate, and one way or another, it goes from a permanent tooth, 4 millimeter class 2, into a class 1. Okay, part of that is lower molar shift, which would be equal to or more than the upper rotation. Okay, and bite change in the growth. Differential horizontal growth there is on all these cases. The question is, does the bite change, okay? Or do the teeth just move with it? So there is the mandible is growing further forward than the maxilla. There is maxillary drift, that's the bone, but he was talking about the teeth. So you go more mandibular growth in everybody than the maxilla. The question is, do the teeth follow? And the interdigitation of those teeth keeps them kind of going forward. If you can imagine, a 4 millimeter class 2 doesn't really have interdigitation. So that lower molar can slip forward into an occlusion with the upper molar. Say it another way. That's the way I understand it. Does that work with you, Ben? Or did I answer the question? And also I said that the lower 7 pushes that lower molar forward. Any more questions?
I just always remember in my head, once a class 2, always a class 2. And I tend to see that.
Okay.
When that transition is occurring, when those E's fall out, I sometimes will see less class 2, but then when the upper E falls out, it comes back with no treatment.
Okay. All right. Well, that is hearing it from a guy that works with kids all day, every day. Okay. Okay. We can still, don't worry. We can still go on with the presentation. It's okay. It's okay. Okay. So once a class 2, always a class 2. Okay. Well, let's try to get in the way of that. Okay. So we have teeth going everywhere. Let's agree on that. Okay. Okay. What we're trying to do is direct them in the place that we want them to go. So Ben has a very good question. How do you change once a class 2, always a class 2 into a class 1 predictably so you don't have to deal with the class 2, right? Let's do it. Let's do it. Let's do it. Let's do it together. Okay. So the face in growth. So I can tell you for sure that the face enlarges downward and forward. Absolutely. Every patient, their face gets bigger. Okay. And the mandible will naturally grow forward horizontally more than the maxilla. Absolutely. Every case is going to happen that way. How much more forward? That's a variable. I measured that differential horizontal growth meaning horizontally, how much more does the mandible grow, the jaw grow? How much more does it enlarge than does the maxilla drift forward or enlarge? And that is a differential horizontal growth. Now, that does not change the bite by that amount. I'll say that again. That does not change the bite by that amount. The question then is, do the teeth follow and stay in occlusion during that growth period, or do you get less horizontal overjet? Okay? Anterior overjet of the teeth. Okay, so the bite changes. The question is, does the bite change due to differential horizontal growth? It should be accounted for, if we can, in a diagnosis on growing patients. So the first thing that you must do is recognize and show any third party that you recognize it was a growing patient. That is basic to the specialty of orthodontics. That's about all they ask them. They say, is this a growing patient? Yes, it's a growing patient. It's going to help you on class 2 cases. Yes. It's going to hurt you on class 3 cases. Yes. Okay. That's how much you need to know minimum. Okay. Anything after that is just a bonus. All cases in the mixed dentition are growing. They are all growing. I guarantee you. So let's look at this one. A 7-year-old girl, she has a WITS. The WITS is the skeletal class 3. So the bones already are in a class 3 position, not very much, just a minus 1.2. Remember I said plus or minus 1, right, is class 1 skeletal. So a 1.2, is that class 3 skeletal? Not really. It's just 0.2 millimeter. Okay, come on. Let's get real here. Okay? And if I look at the lines here, I see a class 3 dental in the terminal plane of the primary molars. You see that? So the upper primary molar is further back than the lower primary molar. That's class 3 dental. Slightly class 3 skeletal. Now, let's look at the growth from my study of a class 3 female. They have tremendous differential horizontal growth early. This is the stage of growth. 0 to 1, in other words, very young. This is stage 1 here. This is stage 1, cervical vertebra, flat, 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 stage 1. Okay? So tremendous differential growth. Now, do the teeth change to more class 3? Well, they're tending that way, but they may keep up with it if you have some overbite that they can lock into. Okay, so the lower incisor may start leaning more retrocline back, or the upper incisor may procline more, accommodating this extra mandibular growth. And then down here, as they grow, it rapidly declines to where latent growth, chances of a girl changing into to like a surgical class 3 case is almost nothing. Okay? So that's the growth pattern of a class 3 case. Now, this little dotted line, this is the mean, and the dotted line is the first standard deviation. Okay? All right. So this is a 2 millimeter bite adjustment that I make in the lateral ceph to protect myself against being surprised by having all of a sudden edge-to-edge incisors in class 3 bite. So this is what I've been doing. Okay? So now we get incisors more edge-to-edge, and that's our case on a growing patient. So I factor a certain growth into the diagnosis. Now, if the patient does not do that, and they do not grow as much as I factored into it, well, then that's easy. If, I don't have to worry about it. If they grow more than this, well, and I didn't factor in enough, well, in a liner treatment, you may get posterior open bite if you don't factor in enough. Okay? You'll get the incisors colliding together. They can't procline upper, retrocline lower. They slam together. The aligners won't let them do that because they're not programmed that way, and now you get posterior open bite. That's one of the, I've got a very nice class 2 case where I actually factored it in, but she grew more than expected. Okay. And I'm sitting here scratching my head. How come I got a posterior open bite? Because in the progressive aligners, you don't see posterior open bite. And I had one, and I'm going, what is it? And it was growth. Okay, here's a boy. He has a width of a plus 2.1. Well, that's not much of a skeletal class 2, but it is. And if I look at the wrist X-ray now, this is a stage 1 wrist, stage 1 cervical vertebra. He has a lot of growth to go. This is in at 2 millimeters of a differential horizontal growth. It is growing every year, but is declining slowly. And when you get out there at the end, well, there is very little difference between the growth of the mandible and the growth of the maxilla. Now, the question is, once a class 2, always a class 2, like Ben just said, we're going to have this continue even though this is going on. The mandible's growing forward. You say, oh, it should change. But it doesn't change because the teeth are compensating for that. Okay? So we have a little bit. So let's get down to what are we going to do about this? Okay? We can't predict it. We just know what's happened. First of all, we're going to say we're going to make a preliminary non-extraction diagnosis, and we're going to ride along with this until we get to permanent teeth, and then we're gonna straighten the teeth and get the best bite. Okay? Now, factoring growth into these aligners, remember I said we're going to do year by year. We're going to just go for a year. Let me have well, probably 25. That'd be every 2 weeks. You could change the tray. In a year, just give me 25 trays. I want you to straighten these teeth. I want you to do this. I want to move the distal. I want to rotate the molar. I want to do these specific things. And then on this class 3 boy, I said, well, give me a little extra anterior overjet. Now, if I say 3 millimeters, then I get some weird stuff. They don't know what to do with 3 millimeters. The normal would be overjet and overbite is 2 millimeters in aligner instructions, programming. So I'm going to say, give me plus 2 millimeters instead of the standard 2 millimeters. And I could say, give me at an endpoint of class 2, 1 to 2 millimeter canine, or 1 to 2 millimeter class 2. Whatever you want to say it, that's another way to communicate how you want it programmed. Bottom line is you want this right here. You want space on all your growing patients in your aligner setups for a 1-year setup. Then after 1 year, you'll do it again. And you say, well, are they still growing? Yes, they are. Okay, I want this again. And guess what? By the end, you'll get just about what you want. Or you can write me an email and say, you don't know what you're doing. Okay, another way in your class 2 cases to disrupt the bite and increase the dental change as these bones are growing disproportionately is you could bond occlusal to the molars. Now we do that in brackets, don't we? Well, you can do it at that in aligners too, You just have to ask for occlusal pads, and they'll give you a cutout in like progressive aligners, and then you take some composite acid etch, put it in there, put the aligner up and down so you can remove it, and then you leave a little blob of composite there. How thick do you make the composite? You make the composite thick enough to where when they remove that aligner, that they're biting on composite and not on their teeth. So now you are discluding the teeth, and you'll get more of that extramandibular growth versus maxillary drift, he wanted to call it. Okay? That's true. So there's a method of growth management with an aligner. The aligner itself, if they wear it enough hours, will help you with that too, just disrupting the bite. Another way, incisal ramps or turbos. These are built into the aligner. You don't have to do anything. They just come with them already incorporated into the plastic. So that's nice. I don't have to even etch and put a little blob there. I can just ask for curved bite ramps. But for that, you have to have a small amount of overjet. You cannot have a big overjet because otherwise the ramps, just close, the lower teeth close in behind the ramps. They don't bite into it. Now, in progressive aligners, they do have some curved ramps. And I've only had one case where we got some curved ramps because it was close enough where they could do ramps, and they have a little curve to it that holds the jaw forward, holds the lower forward. Dr. Isham, what have we got here?
Yeah, so
the question is, with a blob of composite on the molars, will that intrude the molars? Well, yes, it will, especially if you, it should be about the same as you would with brackets. But with brackets, you could have extrusion of all the other teeth with that. So in intrusion in the aligner world, they use this in open bite cases. And they may put this on 6s and 7s in open bite cases.
So if the patient has a deep bite, would you still put turbos on the 6s?
Well, you prefer on a deep bite to put the anterior bite ramps where you can. Where you can. Where you can't is when you have too much overjet.
So if you have too much overjet and a deep bite, it's a tough situation.
Well, if you're doing growth management, then you'll accept some molar intrusion for the class 2 correction.
For the AP.
But to answer your question, I don't usually do that. The aligner's enough, okay? I don't usually do that for that. I use those little bite ramps, occlusal pads. I use those occlusal pads for either growth management, for anterior cross bites, where you want to disclude the teeth, and in aligners, it's more important than it is with brackets to exclude the teeth, and for posterior cross bites. I use those for posterior cross bites.
It makes sense.
Okay.
Thank you, Dr. McGann.
Okay. Well, we're trying to make sense here. Okay. But I realize it's a lot of information, and I don't speak as clear as Collins does, so I'm doing my best. Okay.
I'm enjoying the talk so far, and I'm sure a lot of people are, Dr. McGann.
Oh, good. Okay. I'm doing my best. Okay, so when can I start treatment? Well, you've been seeing some bubbles here. I think you saw some on this one. You see the bubbles? You can have a bubble on top of an existing tooth. You can have, which we know is going to fall out soon. That's why it doesn't have an attachment. We put attachments on primary teeth that we know are going to be there for a little while. If they're going to fall out immediately, well, we'll put a bubble there. Although you could say, well, if you if you manufacture the appliance over that tooth, then you should have a bubble anyway. Yeah, but it doesn't hurt to put a bubble. Okay. So they got a bubble, a bubble, a bubble, a bubble, a bubble. That's for the eruption, to leave a space for the eruption and to maintain these other teeth from going into that space. Okay. So we got bubbles. This one, you could start treatment. There was a space between the two central incisors, and the lateral incisors were being blocked out. There wasn't enough space for them. So instead, we said, all right, let's close the space of the ones, and let's put a bubble. How big? Well, upper laterals are usually 7 millimeters, sometimes 7.5 if they're big ones, a little less than 7 if they're smaller ones. Okay, so you overdo it. All you do is say, I want a bubble, and it's best to say, I want a bubble 7.5 millimeters, or 8 millimeters would be too much. Okay. And so now there's a space reserved for the eruption of those lateral incisors. So you can start a case before the eruption of lateral incisors, and you say, well, what about the canines? You know, they're way up there. You know, this is too early. I never started a case this one, because dental age 8 is what I taught you in the brackets, where you have full eruption of incisors upper and lower. That's when you can start, and then you have to make sure that the 3s are safe to the 2s, right? Okay, so let's look at the 2 versus 3 roots. Would you all agree that this is too high to put a bracket on the lateral? It is with brackets. See, brackets have built into that lateral bracket, there is a distal root tip on all upper lateral brackets, Roth included. Okay, there's a distal root tip, IP included. Now, to expect people to off-center those so they could bond that lateral is asking too much. There's too much risk that the distal root tip is going to push that lateral root into the canine that's erupting and either resorb the root of the lateral incisor and or impact the canine. So we say, don't do it until the tooth is at least a quarter root way down the root. This one's not even qualified. And even though there's no overlap, this is the bump you're looking for to find out if the canine is on the labial or the canine is on the palatal if it is absent. And that you use your finger. And I can tell you, I don't know, let's say like 50 consultations where there's an overlap with a lateral incisor and a canine. I can't tell you, yeah, there's one, probably Dr. Hisham. But everybody else, nobody says, yes, I took my finger and it's on the labial. I'm sitting there looking on the photos, looking for this bump, and if I can't see it, then I guess it's probably on the palatal, you know? So I would sure like to reach into that photo and see if I could feel the canine. So lateral incisor brackets, we do not want to do this, okay? But we can start an aligner with this, and I'll show you how. Let's see. Not yet. That one. Okay, next 2 slides now, I'll show you how. Okay, so how about this one? We have some spaces. We got the lateral too close to the canine. We do not want to push those laterals laterally into the canine eruption. So on the upper, you can do it on the lower. It's actually, I don't think I have one case where I've seen on the lower that putting brackets too early. But you probably wouldn't want to do it on that either. So can you start it? Because you say, I want to get started on those spaces and deep bite. I don't like that. Spaces, deep bite, that's a bad combination. I want to get going right now. Okay, well, you can. Here's how you do it. You make a setup, and then on the tooth movement tool, you look at what happens, the root apex. You have a choice of crown or root apex. We don't care about the crown. Yeah, the crown will go mesial to close the space. Okay, that's fine. It's also coming back. You can see here on the superimposition that the incisors are coming back to close that space. So what we want to know is what happens to the root apex. Well, whenever you have here, it says like degrees, that would be an angle. If you don't see degrees, and that's in millimeters, they don't put it that way. So it says here, on 2.2, you just click on 2.2 on the setup in progressive aligner. You just click it on there, and then you say, and then you put it all the way out to the last tray, and then it says, all right, we have 1.4 millimeters of lingual root translation or millimeter movement. So the upper lateral is going, the apex is going back 1.4. Well, we don't care about that. That's okay, just as long as there's not an impacted tooth there. But what we are concerned about is that we don't have the root moving distal. So this one, it has 0.6 mesial. And if you say, wait a minute, I want that triangular space right there to be fixed, that triangular space, that's moving the root to the distal. That's bad. We don't want to do that. Okay? So you leave the triangular space, you leave in favor of the mesial root movement, and now you can start the case. Now, if they send it back to you on the setup and it says distal translation, and you have this panoramic, you just say change root apex 0.6 mesial trans to, or let's say it said distal, to 0.1 millimeter, 1 millimeter, 1.0 millimeter mesial trans. Done. It'll come back exactly like that. You may have a bigger space here, but that's what you do. Okay, so you specifically tell them no distal root trans. Okay, or you could do it by the mesial angulation. You could also do it that way. The apex mesial angulation. Okay, so here's one. Here's another one. This one, we click on 1.2, and we have some, something similar. Looks like the same case, maybe. And this one has 0.5 mesial trans to keep that lateral root away from the canine. Move it mesial. On the next set of trays, if you want, you can move it distal. But right now, keep it mesial. And here's how you do it. You just click on the tooth on a setup, make sure it says mesial trans, and if it doesn't, make sure that they change it, okay? Give them an instruction to change it to mesial trans. Keep it away from the erupting canine, and now you can start the case with an aligner where you couldn't start it with brackets. How about this one? Unerupted 1.2, 1.2. This is that same one. We've got a big space here. We don't want to wait for the laterals to come in. Matter of fact, we want to make more space for the laterals. So let's close that space. Now we are committing ourselves to aligners now, because you're going to probably not do a 20 tray aligner package. for phase one, and then have to transition them into brackets later. But you could. Chances are you're going to go unlimited, and there's issues there that we'll talk about. So this one, the central incisor, roots mesial. At the same time you're rotating, okay, a 19-degree mesial rotation, that's an advantage. Let's fix that while we're at it. Make some space and put bubbles for the laterals. When the laterals come in, you look and make sure that the canines are okay, and if they're not, you keep the laterals more to the mesial. Okay? So you have crown, and then you have root apex. 1.1 millimeter mesial trans. And it's okay in the mixed dentition where you have one series of tray, you do one thing, and then on the next series of tray, you can do something else. It's okay. All right, here's one where this was not an aligner case that I did, but just an example case where one side, the 8-3 is missing prematurely. We have shift of the incisors, making this midline problem here. Okay, we have a deep bite, retrocline incisors. Here you'd have to use an upper utility arch, and then after you create some overjet, then you'd have to use a lower advancing arch. I will not ask for a show of hands who wants to do that. So you can instead choose, say, ma'am, I'm going to treat your kid just like my own. If this was my own, I would use aligners on this case. Aligners start to finish. Do you have 5 years? Are you going to be done in 5 years? Well, we're going to get to that in a minute. Chances are you're going to get done in 5 years, okay? But if you're not, well, we got to talk about that too. So you say, I'm going to get a 5-year aligner package, and for the first year, I'm going to intrude these incisors, upper and lower most likely. And is intrusion easy to do? How many fixed cases do we even get? And we're still looking at deep bite after 2 years, It never really leveled. It never really got there. So spend a little bit more time on it in phase one. Let's intrude upper and lower on these trays. Let's straighten these teeth. Let's get some overjet. Let's advance those lower incisors to coordinate with the upper, and let's get 2 millimeters plus anterior overjet. I got a growing patient. And let's see, what's happening in the molars? Okay, and then you can look back at the molars. Is there anything I want to do back there? Do I want to rotate things? What do I want to do? Okay? And you ask for a 7 millimeter bubble for 8-3. Is it going to be exactly 7 millimeters? I don't know, but 7 millimeters close enough. Okay? So for for the upper canines, I asked for 8 millimeters. Upper lateral, 7 millimeters. Lower canines, 7 millimeters. Okay? Bicuspids, 8 millimeters. Okay, so let's talk about first molar rotation. The buccal may look class 2, but the palatal may be class 1. First molar determines the positions of the 5s and 7s. We want to know that. That's just basic information. And rotation is best in the mix before the 7s erupt. I will cover that. This one, the 7s are already in place. This is my example case, okay? Permanent dentition, easy for you to imagine. And so do you see that there's only about 1 to 2 millimeters right here of class 2 on the lingual? but there are 6 to 8 millimeters class 2 on the when you view it from the buccal. Well, this is this mesial rotation of the upper molar. Okay? And you will almost always see a mesial rotation of the upper bicuspid, of the upper second bicuspid. Whenever you see this, okay, you'll almost always see that. So usually in this aligner thing, I would say distal rotation is, in our terminology, a mesial rotation, but you want to rotate the tooth distal. You have to think the opposite for the technician. A distal rotation of the upper molars and the upper second bicuspids, a distal rotation. And then you ask yourself, do I want to distalize even more with the 7 present? Okay? So let's look and see how much you might be able to get. In other words, we said there was 6 to 8 millimeters class 2 on the buccal, and on the same tooth from the lingual, from the palatal, there was only about 2 millimeters. So is that rotation possible to be that much? Well, let's look at it. In the instruction, you could say rotate the upper 6's distal around the palatal root axis. What's the palatal root axis? That's this right here, the palatal root. Around that, and I've drawn a circle here, and I've taken from the mesial buccal cusp that you think is a 6 to 8 millimeter class 2, and I have rotated that back. And how many millimeters do you think that shows from here to here? Looks like about, I don't know, I don't have a measure of it, but looks to me like it's about 4 to 5 millimeters. You can also look at the mesial rotations from the mesial contact of the 6's. Instead of that being straight, like you can see this contact, if I had an arch wire here, it'd be the perpendicular to the arch wire. This one is at a big angle to that arch wire. Okay? So we want to distal rotate the bicuspid, distal rotate the upper 6, and maybe even distal rotate the upper 7. That can all be done easily with an aligner. All you got to do is write one line. Tell them what to do. But the PA technicians will do it on their own, tell you the truth. But you may want more than they put, okay? Okay, so we do a preliminary diagnosis. We can't see, we can't predict. We're going to confirm it at each step. We're going to make a preliminary diagnosis of non-extraction to be confirmed after full eruption of the secondary teeth, 6 to 6, the start of class 2, of phase 2. Okay? The preliminary diagnosis will always be non-extraction, or we're not going to do aligners. We're going to do brackets. Okay? And you can start early. When more is known, we're going to remake decisions at every step, at every checkpoint. Okay? I think checkpoint's a good way of saying it. Only choose non-extraction, and then you got to make a distinguishing phase 1 versus phase 2, especially if your fee is for phase 1 only. Now, I don't like phase 1 only fees. I will tell you why I don't like phase 1 only fees. I know they're cheaper, they're easier to sell, they're, the parents don't flip out. Okay, but you say, I don't know how many cases where I got done with phase 1 and the parents said, oh, that's good enough. That looks good. Their teeth are pretty straight. We don't need to put all the brackets on, and I don't have to pay another $2,000 to finish this case. Instead, you say, no, from the very beginning, I have a 4 to 5 year case. and we're going to do phase 1 and phase 2 till we're completed. And if you won't agree to that, then I guess I'm not going to do the case. It's okay. Or we'll wait. We'll wait till phase 2, and then we'll start it then. But if there's are things that I would like to fix, class 2, deep bite, expansion, there are things I like to do, reestablish spaces between now and to help out the case so it's going to turn out really nice. And I'm willing to put in the extra work. Yeah, I'm willing to put in the extra work. Guess what? The specialist doesn't like to do that. Either they don't understand it or they don't like doing the extra work. So I think they don't like doing the extra work. They want to wait until all the teeth come in and then boom, boom, phase, do it in one phase. 2 years, take out teeth or not. It's not their teeth. It's okay. Boom, boom, boom. So let's figure out how we're going to monitor this, okay? How we're going to plan it. And I think from a parent's viewpoint, what they want you to do is to plan. There's a plan in place. I'm going to treat them just like they were my kid, and there's a plan in place. I know where I'm going. All you got to do is just get the kid here once in a while when I tell them I want to take another look, and let's go do it. And yes, it may take 4 to 5 years. Okay, it might. Okay, let me turn off my ringer here. And then you may have the patient in every 3 to 4 months for observation visits or to check the trays, see where they are. And then in between, you may say, okay, we want another set of aligners. We still have things to do, or we're going to go to retention aligners, and I'm going to get to that later. So this is the same lower 5 classification to plan your phase 1, and so this is a quarter root. Okay, it's 4 years if it's no root, just crowns, right? It's 4 years. This one is 3 years. Then you get 2 years, half a root, lower 5. This is my system that I came up with a long time ago, and it works good. This is 2 years, half a root. 1 year is when the teeth are really breaking through, and we figure 6 months after emergence, alveolar emergence. So when this comes through in 6 months, then you've got another 6 months until full eruption. So this would be 6 months until, because this upper 5 is just coming in. Okay, so you got 6 months to wait to start the case if you're waiting for all permanent teeth to be there. Notice that the 7s are already in place on this one. So the 7s came in before the upper 5s. That happens about 50% of the case. Now, on these x-rays, I also want you to note there is a general mesial crown inclination of upper molars, but it can also be lower molars. So let's look at that. I want you to look at this on your eyes, because this is something you can do with an aligner very easily. And it's not only the distal rotation, but it's also the distal crown tip. Now, before the 7 erupts, do you think I could tip this crown to the distal? Yes, I could tip that crown to the distal. We do this with the tip welds on the bands, but most of the time that's in the, when all the teeth are there and the 7's already present. But an advantage, you can see this one here. This one looks like it's already tipped back. So there's no reason to tip that one back. But this one has a mesial inclination, and so you have some advantage to tip it back. This one looks pretty much straight up and down. This one, pretty much straight up and down. This one, mesial inclined, but it has a 7 there. Okay, so you say, distalize the 7, distal crown torque, 7 and 6, and distal rotation, and you'd be amazed how much class 2 you can fix. Okay? So, once a class 2, always a class 2? Yeah. If you don't derotate the molars and tip back the crowns, then it's going to come in class 2. So, Ben, my answer to you is this. Go back, look at what you can do with the upper molars, taking the rotation out, and the crown tip back. And then the 5s will erupt more to the distal, and all of a sudden, they come in class 1. But you have to do it early enough. Okay? And it has nothing to do with the mesial drift of the growth and this and that. Okay? All right. So, can you do this with a bracket? Yes, you can do that with a band. On our Roth bracket, we have a 10-degree distal offset on the upper molars. That means that takes out that molar rotation. And then we can also use a non-extraction number 1 arch wire that adds to that rotation correction. And then we can do a tip distal weld on that upper one, and we can tilt that back. But that's only like 3 degrees or something. That's not so severe. On an aligner, you just say distal rotate, distal crown torque, and then you look at your tooth movement table. And if you want more, you say change the distal rotation from 10 degrees to 15, and they'll do it immediately. Okay? So year by year, we're gonna estimate the time until full eruption based on what? Based on this. Based on the lower 5 root formation. That's been in place for, I don't know, 30 years now in POS, okay? Been a long time I've been doing that. So you're gonna have eruption of 6 to 6. That'll be the start of phase 2. Half of them may have the 7s erupted, half of them don't. Okay? All right? So you say, give me a year's worth of trays, then I'm going to make a refinement, and we're going to include the 7s. Okay? So the parents want you to make a plan. This is how you make the plan. And it's okay to do nothing for some years. That will call it a pause. But you want them to keep making their payments, so don't say you're doing nothing. Observation visits every 4 months, so they don't have to come in every month 50 times on a 4-year case. That is too much parent stuff, okay? After COVID, nobody wants to leave their house. Make your appointment in advance as a hygiene. Okay. In hygiene systems, they say, okay, let me see you when you want to come in. 4 months? Yeah, I go in every 4 months. And so I say, yeah, okay. Though you want to make your appointment? Yes, I do. Boom. And then they have a confirmation system to like remind me I have an appointment coming up. Now, do I want to start this case? Absolutely. I want to start that case. Now, the question is, with this thin tissue, is this going to be non-extraction or extraction? This one's close. Okay, a lot of crowding, thin tissue, but that could be from trauma too. So don't jump to the conclusion. Do I want to start this one? Yes, I do. I got a posterior crossbite. I got an anterior open bite. Those things go hand in hand. I want to start this case right now. So do I want to use rapid palate expanders, TPAs, brackets upper and lower incisors, or do I want to use aligners? It's on a case-by-case choice. So you plan no more than 26 trays in a series. That would be 2-week changes for 1 year, or 1 week change, and I'm sure they can change it at 1 week, because we got big periodontal ligaments They could definitely change it in 1 week. The question then is, do I want to make another series in 6 months? They'll run through their trays too darn fast, okay? And if it's a 4-year case, well, I'm doing too many refinements, okay? So you ask for 26 trays, and then they do what you ask them to do. Could you please rotate the molar, intrude the molars, extrude the incisors, intrude the molars, extrude the incisors, okay, on an open bite case. Posterior crossbite, give me an occlusal pad. All you have to do is just write the sentences. This one, I might say, I'm going to be taking out the canines. I'm going to take out the canines. I want you to line up all these teeth. I want you to give me 8mm bubbles on the upper and 7mm bubbles on the lower. Straighten the teeth for me, please. Okay? Oh, and I want to expand. I don't want everything going advanced, and I want lingual root torque on 3-1. And then check your setup. And if you like it, buy it. If you don't like it, probably change to extraction. Okay? That's probably what it is. Okay, so you can use that too as a change to extraction on your preliminary diagnosis. You can see a setup. I'm going to show you, though, that a setup is coming that you're going to be able to see, and it'll be right in your office within minutes, okay? You don't have to do anything. Well, you have to do something, but it's very little. Your staff can do it. Okay, so this one, let's just look at this. We have expansion. 3mm, 2mm. Can I do this in the mixed dentition? Yes, I can. I can push out not only permanent molars, but primary molars. Okay, I can expand. Can I close this space? Yes, I can, making more space for these lateral incisors. Can I push the lateral incisors out? Yes, I can. Maybe I want to take out the upper C's. Maybe I don't. Give me a 7mm bubble right here, or make like 7mm so this can push into there. Go ahead. Let's start right now. Fix the anterior crossbite. Okay. Are you sort of getting it? Now, this is how many trays do we need? All right. So this one, 3-1. Is our biggest rotation. It's 29. Let's call it a 30-degree rotation. Does that make sense to that archwire? Yeah, it looks like about 30. 30 degrees times 1.5. Now, normally in the permanent dentition, I multiply it 1 degree per stage. In the mixed dentition, I say 1.5 degree per stage. That would be 20 stages to fix that rotation. So I can fix that rotation, do the expansion in 20 stages, I may still have some lateral incisor work to do, but give me 26 trays. Let's see where we go. Okay? So year by year, phase 1, close space upper 1, advanced, you see the proclined and advanced. And if you want, you could paint the inside of the pontics, but I don't know. At that young age, you don't need to be doing that. Expand upper primary canines and molars. Align the lower incisors, procline and advance. Expand the lower primary molars and canines. Then the second year, you get another set of trays. You make a new scan, you resubmit again, and by the way, you don't have to go through every detail on these setups at this age. Just get everything moving in the right direction, and then we'll do it again. Okay? And then when you get to phase 2, then you can start getting down to every little every little detail. Refined upper and lower 2 to 2. Then place bonded retainer wire. Okay, you can do that instead of a set of trays that they wear at night only, changing once a month as a retainer, but do not ask for retainer, okay? If you ask for aligners, do not ask for a retainer. Find something for them to do and tell them you want 12 trays, okay? That would be changing once a month, wear them at night only. Third year, new scan, every 6 to 12 months, wait for eruption. You do 3 years of this. Here's a setup. You want you want to make space here. Here's a setup, and then you check the roots of the 2 and the 3s, and you go to work. Start it up, and then you look at the molars and see how many primary teeth can take attachments. In this case, all of these primary teeth can take attachments. They're going to be there for a while. This one, say, no. Now, this one, upper 4 and 3 on this side, no attachment on that. But okay, put an attachment on the 6. That might be on the E. That might be there for a year, and definitely put an attachment on the first permanent molars. Okay, so we're gonna choose attachments based on how much root remains, and these are mostly retention attachments, but it's also to control some of the tipping that you might have if you were doing expanding or that sort of thing. Okay, now protocol for aligners on adult patients. When you do a refinement, you remove all the attachments, you start over again, put on new ones, but everything is very refined. In the mixed dentition, everything is not refined, so it's okay if you just leave on all the attachments. Okay, I would just leave them on. Don't ask them to take it off. Just leave them all on. But on a molar, sometimes maybe it broke or something, you can say, replace that attachment with a new one. So they virtually remove that existing one that's probably broken, give you another attachment, and then when the patient comes in, you just grind it off and like rebond the new one. Okay, and there is something in the setup that has an attachment replacement on that tooth. That's what it looks like. Occlusal ramps to aid intrusion and growth. Those are easy. You don't have to bond anything. You don't have to etch anything. They just come in the tray. So use those whenever you can. And then I put down some of the submission instructions that I've been using. The first series should be 25 stages, approximately 1 year at 2 weeks per tray. You don't have to tell them that. You just tell them, I want 25 trays. You're going to bond attachments, and I think it's a good idea to specifically say which teeth you want attachments on, correct rotations, and continue until 2-degree overcorrection, 4 degrees if it's a severe and a key 2 overcorrection, and I do 6 degrees on some of them. Will it go 100%? No, there's some inefficiency. So factor in overcorrection. So maybe you stand a chance of getting a full correction. On your IP brackets, there's a 4-degree difference in the cut on a rotation bracket. Turns out perfectly straight. You rarely see overcorrection. And if you do, it's so minute you can't see it. But you can see it sometimes if you're looking for it. And add lingual root torque on 3-1. That was the one I showed you. Endpoint. This is very important. That's why it's in yellow. Endpoint. Overbite 2 millimeters, overjet 2 is standard. So if you're on a growing patient, 2 millimeters or more to account for future growth. But chances are in 1 year, you're not going to see more than a millimeter of change in the bite due to growth. So you'll get to do it again and again, okay? Occlusal pad, if you're doing posterior cross bites or anterior cross bites, or if you're also doing it for growth, then okay, bonus. Or if it's too much overjet, okay, bonus if you've got all these other features. Some more instructions. Expand posterior teeth, 2 millimeter per side on the lower, 3 millimeter per side in the upper. The upper is wider than the lower, okay? This is how you communicate with them, just telling them what you want to do. So you tell them what you want to do, and then how you want them to do it. Distal rotation plus distalization. So this is not only distal rotation of 1626, which these are not real severe, but I want distal rotation plus distalization to fit the lower molar. So you can see this is slightly class 2. So I want to rotate this back. I want to distalize it and distalize it enough without the 7 possible until you get to this class 1 molar that you're used to seeing. It's okay, overdo it. And then don't forget the angulation, the tip back, the molar rotation, and you can give that instruction on an aligner, and it takes very little skill at chairside. You hand them a tray, show them how to put it in, and wear it. Here's another one. Primary canines to be extracted. Create 8 millimeter space for eruption of 1323. And 7 millimeter space for eruption of the lower canines. Okay? That was the actual instructions on that. So, patient instructions to the patient, they're different than a regular aligner case. Insert the tray over the teeth with fingers only. True. That's what we do. That's the same instruction for everybody wearing aligners. Insert or remove by pulling up or pushing down right and left at the same time. True. These are the same for all people wearing aligners. Wear every night. Do not take to school. Change to the next aligner the first of every month. If tracking is lost, you may change at your directions, change to full-time on weekends or full-time every day. So try this first, okay? And you say, wait a minute, that's too slow. Yeah, but you've got years. So if you only want to do this for a year, tell them to change it every 2 weeks. But you want to stretch it out in your planning year by year. And then you'll take a new scan with new teeth that are in there with a certain amount of the rotations corrected, a certain amount of distal rotation, certain amount of everything, and you're going to do it again. Clean aligners and teeth thoroughly when removed with a toothbrush, okay? That's a little more complicated with the adults. We usually tell them maybe you might want to use denture cleaners or whatever, but usually not. If a tray is lost, use the next one in line and keep your past 2 trays, okay? So that's what you would tell them, the patient and the mother. Here's the features of the consultation. I have a so many year, not month, plan for your daughter or son. This is a prediction of final straight teeth, and I'm going to show you what that's going to look like. It's going to be Medit POS app, okay? I'll give you a little taste of that, okay? I have considered brackets or aligners and feel that aligners would be the most effective for the job. This is your preference. You want to use aligners. Whereas the adult will come and ask her for aligners, you're going to prescribe aligners for the mixed case because it's easier for you, or you want to do certain tooth movements distalization, molar rotation, expansion, incisor intrusion, that is just too much work. You'd rather just do it with the aligners. So at each yearly checkpoint, I will reconsider brackets or aligners. I think that's okay to say. I will treat your child as I would my own. That is powerful. And I for sure do that. The financial agreement is more complicated because if it includes, in my opinion, it should include phase 1 and 2. And in that case, there's only the extra cost. You may want to charge them for phase 2 records and tooth cleaning, right? So one fee, and I'm putting this down here. I know some people don't like us to talk about money, but I'm going to do it anyway. You're going to have to pay for the unlimited trays for 5 years at the beginning of the case. So the first year payment should be greater than the following years. It should at least cover your cost plus some. And so you might say to do aligners, you have to put down $2,000. Where if you were doing brackets, you might say, well, okay, we can start with $1,000 to get started, right? Okay, so but then you don't have to pay for the next 5 years. Discount for payment in full, that I think could be a benefit, and I think a lot of people would do that. Yearly or monthly payments, or pay at each set of trays. Here's another one. You could have them, since you're doing trays for a year or retainers for a year, you could have them, pay for each set of trays. If you want them to be getting something, you give them a box, right? Okay. So are you going to charge for only phase 1? That's a risk that the parents don't want phase 2. I don't like that. And then you have to have a consult at the start of phase 2 to try to sell them again. And they're looking there saying, well, this is good enough. And you're wasting your time. Where if you already have the agreement, phase 1, phase 2, you go out in the waiting room and say, well, it's time to get to the next phase. Schedule them at a certain time. There's no consultation. You could add to that, and there's no extra charge. It's already been included. Thank you very much. We love having you. Insurance, though, may ask you for a phase 1 fee, and you'll send them a phase 1 fee, a part of the overall 5-year, 4-year, whatever it is, fee. Pauses. Do not ask for retainer. I'll say it again. Decide if you need trays in each arch, or you can apply retention aligners to one arch only. And it's possible on a deep bite case, you'll say, just give me 12 trays. Go ahead and intrude those upper incisors a little bit more. And I'd like some anterior bite ramps. Okay? So you're calling them to the company aligners, but to you, it's just retainers. Okay? You're just retaining with an anterior bite plane is what you're doing. So no lab bill there. You've already paid it. There's no hollies with an anterior bite plane, that sort of thing. There's no expansion screws. There's none of that. And I'm sure you can find something to give them some instructions. Rotate this a little bit more, intrude that a little bit more, distalize that a little bit more. And that's where you could go to once a month for sure. So upper trays, I'd say 10 or 12, occlusal pads or bite ramps. That's easier. Or at night only. Trays lasting 2 weeks full-time wear. Should last 1 month. Nighttime wear. So like the tray shouldn't wear out. And it shouldn't get lost if it's up by the toothbrush. And so you go 1 tray per month. Maybe you see them in 4 to 6 months while you're waiting for eruption. And the lower tray, you might be like retaining alignment of the incisors, maybe eruption bubble, or you may be maintaining the molar position that you uprighted. You don't want an E-shift, that sort of thing. Or no trays, just let it go. And then start again. Or you could bond a little wire 2 to 2. That's common too. And I've seen it on the labial surface. The kids, they don't care. Now, I want to say something about the transition between phase 1 and phase 2, because especially if you have insurance paying for phase 1, but also if they move or whatever, and they say, well, are you still treating this case or are you finished? You say, no, I've already finished phase 1, and now I'm just in a retention period waiting for teeth to erupt. You want to define that. So you get new records that identifies this change, that you have finished phase 1 or you're starting phase 2. And that could be just simple as a panoramic and a note in the chart, end of phase 1. You would generally leave your attachments on or replace them until you get to phase 2. When you get to phase 2, you take them all off and start over again. Okay? Then you confirm the non-extraction diagnosis. You do the financial check. New consultation if you didn't include phase 2 in your original. Okay? So, in the transition, it's very important in the field of orthodontics that you make a defined stopping and starting again. That was the previous fee, especially if there was insurance, you had to say it was, and this is the new fee. And the rest is financial arrangement. So, phase 2, evaluate growth, look for signs of puberty. That's just going to help you. 3 to 4 month observation visits until full eruption. The 5th year, after eruption 6 to 6. Now, the 5th year, now, wait a minute, you're getting to the end now. Remember, it's 5 years. So you need to get done here right away. Now, if you run out of time, and you've already got at the end of your 5 years, I've been assured you can buy another year for, I think it was $250 or something, but I don't know the fee. And it hasn't happened. Or you can just change the brackets to finish, okay, if you want. But almost all of them, if you just do your planning right, you're going to get done in 5 years. 3 to 5 case considerations. And don't worry, I'm getting to the case examples. They said you're going to see a case. Yes, you will. I'm thinking right now I might take a 15-minute break when I get to the case, because we're just about there. You want to reduce the patient visits to your practice. You don't want to bringing them in there 50 times. They'll get really tired of you. So 3, 4, 6 months. We'll talk about other choices. You could even make it more than that. Office visit at the end of each series of trays. That could be 6 to 12 months. So you could identify that. So you come in at the end of each series of trays. Here's your 1-year set of trays. If you have any problems, call us. If you lose, all of a sudden they don't fit anymore, well, let us know, okay? Limit of 3 years consecutive on dental monitoring. We're getting to dental monitoring next, which is only 3 years. So if you go longer than 3 years, you have to buy another package. And then wait until the last year of phase 1 to start dental monitoring. That's another choice. You don't have to dental monitor during phase 1. In other words, phase 1 is not so critical. If they lose tracking, okay, so we get a few more trays. If everything is not completely fixed, it's okay, we got time. But when you get to phase 2, well, it becomes more critical. Now maybe you want to do dental monitoring. But some of you may want to do dental monitoring for all of your cases and use that as a method that that the parent does not have to bring the patient into the clinic as many times. So if you're in a busy practice and you don't want to see the patients as much because you're too busy, this is for you, okay? And this is what the orthodontists have been doing to like reduce the patient flow and to work less days in the office. So this is how they work 3 days a week or even 2 days a week, and they pile in the patients. And so they use aligners, they throw in the dental monitoring, but you can also use this for brackets. We're working on that to like refine that. And this should be out within about 2 weeks, according to Miles. He's just talking with the company about a lot of different issues. So they want to cut back some of the features. We want those features. So anyway, okay. So anyway, the patient has a holder for their phone. The typical offering, one of the problems he's having is in some locations, they're going, wait a minute, all of our users have been paying this, and now you're going to give them this for this? Oh, no, we can't have that. Otherwise, we're going to look bad, right? So this is cheap, okay? So this is in U.S. prices. If you have like progressive aligners, $330, but I think he's working on some other feature that we want that may be a few more dollars. Anyway, you have a scan box, and so the patient gets a scan box, and then they use their phone. They take weekly photos. It goes into a computer. It then tells them when they can change their tray or not change their tray. 3 years consecutive is as far as it goes. So you could offer this as a patient as an option to reduce visits to the practice, and the doctor is monitoring their case closer for maybe an extra $500 or include in a phase 1, phase 2 total fee. Just some ideas there. Okay, so this is it here. We are setting up all the details of monitoring for you so you don't have to do it. And we send you reports, and that's part of our service that we're going to do for you as our POS family. So actually, it's going to be the Indian dentists that are going to be monitoring this. So it's incredible all the options we have in our worldwide of POS. Is just amazing. Okay, so why dental monitoring? Well, better patient compliance and confidence, and this is especially important when you're working with adults, or maybe if you're doing night-only wear with the kid, this would be important. It'll tell them when they can change to the next tray. Maybe it's not a month. Maybe it's 3 weeks. Maybe it's 5 weeks. Okay. See the patient every 6 months. Oh, and you would get a report that it wasn't tracking. So then you call them up and say, wait a minute, you don't have to come to the office, but I want you to start wearing this more. You're losing tracking. Okay. And if it doesn't improve, you're going to have to bring them in, and we're going to have to get another set of trays. So there's a lot of value here to it. But if you don't have a busy practice, well, you want to see bodies in there, so bring them in. So it's not as important. So it's basically to avoid overactivation. Change your trays too fast and losing tracking, and eliminating nothing to do appointments when they come into the office. You go, oh yeah, everything's doing great. See ya. And they go, did I pay for that? I don't know. Okay, so I'm going to take a 15-minute break just to drink a little water here. I'm getting a little dehydrated, I think. And I'm going to set my alarm for 15 minutes. And then we're going to come back. Dr. Hisham, who is here with us, and he is our VIP. And we're going to these 2 cases are his. I don't have a clinical practice, so he's my practice, and he's my hands. And he and I have a really good back and forth, on what we should and shouldn't be doing. He took the 48-day course, and then he retook the series again. He's very academic, and he knows what he's doing. And then he completed the Aligner Plus series. And so this is what he said when I asked, what you've been doing here. I think I got more than 50 cases with him already with just mentoring, but I don't know. So he likes the aligner. So that's what's going on. So when we come back here, we're going to start with our case, and done by it's a case of Dr. Hisham here. Okay, that's going to be it. And then we're going to, so 15 minutes from now, I'm going to start again. All right, so let's get a move on here. So this is an 11-year-old boy, so we're talking something a little later in the mixed dentition. And then the next case will go much earlier in the mixed dentition. And this is just the basic part of it. This is not every case situation that we see, but you can see that Dr. Hisham makes some nice records here. He's got the resting lip, the resting upper lip, which tells me that the vertical is fairly good. We have a little bit of deep bite, probably caused somewhat by over extrusion of the upper incisor a little bit, and over extrusion of the lower incisor. Okay, so 11-year-old boy, mixed dentition. We got blocked out lower lateral incisors and deep bite. And is this no, don't answer me. I shouldn't ask those questions. This looks like a mixed dentition class 1 from the terminal plane viewpoint here, right? If I draw a line right here, that's my terminal plane on the distal of the primary molars. So class 1 there, and maybe a little bit, oops, sorry, wrong one, right there, class 1 right there. Okay, so then, and then if I draw a little line across here, I didn't do that right. Cusp tip, I have some extrusion there. And I think this was the one that we did before. We draw a line there, we have some extrusion. So deep bite with aligners or with brackets, one of the main things we do is that we level upper and lower. We level upper and lower. So, and this is where in the automatic system, we're going to make the occlusal table, this posterior occlusal table here, and we're going to level upper and lower. That's going to be our number one method of correcting deep bite on the anterior teeth. And we're going to be looking for curved spee, upper and lower. I know you're familiar with lower curved spee. We do it on every case, but we're also looking for an upper curved spee. This had an upper curved spee, okay? Super erupted upper incisors. Crowding, okay? We can wait on this. We don't have to do the crowding right now, but hey, why not? We can start straightening the teeth. That's what they want. We can start intruding, leveling. We can, if we look here at the molars, I don't see a lot of molar rotation. I don't see a lot of molar rotation here. So this is not necessarily going to be corrected by molar rotation and distalization. We'll see as we look at the tooth movement tool. It's not going to hurt to over rotate, and then later on you can rotate. So let's look and see what the lingual looks like. So we can see on the labial or on the buccal, it looks class 2, right? If we look at the palatal cusp on the lingual, this is a class 1. Looking to me, this is a class 1 palatal cusp. And once I started using scans, which was, I don't know, a year or two ago from you people, because I wasn't personally using the scans, then, and doing my scanner project, which, by the way, all scanners can be used in the new software that we've been writing for 5 years. Okay, so all scanners. There's nothing that you have to buy. You don't have to go buy another scanner or anything like that. Okay, you can use this scan. Well, and that was my first project. That was a lot of people helped me with that. They had a lot of different scanners, and I was making sure we could use all of them. So, and then the occlusal plane here, which will in 3D be an occlusal table, I chose the distal buccal cusp of the lower permanent first molar. Unless it's not there, then you use the primary molar, and the lower first premolar, the buccal cusp tip. But if that's not there, then you use the primary molar. So in this case, it was the distal buccal cusp of the lower 6 and the buccal cusp of the lower 4, and this is our occlusal table. Now the upper would be where this would fit into, and you can't see it very well is because it's marginal ridges and stuff like that, but in the 3D, we'll just have one occlusal table. I just did this here for information. Okay, so the most important thing is here that you recognize what a lingual class 1 looks like, okay? Because you're going to be looking for that now all the time, now that you know it, right? Okay, so the frontal ceph was good. How long do we have until full eruption? That to me looks like 2 years. Okay, looks like about half a root formation, maybe a little more. So probably about 2 years. So I'm going to plan 2 years. Now, am I going to put an attachment on that lower molar and that lower molar and that lower molar and that lower molar? Yes. I'm not going to put an attachment on this one. That one is already resorbed. This one, I don't know if the attachment would hurt anything, but it's not going to help anything. It's just something else for me to do. But I definitely want an attachment here, want an attachment there, want an attachment here, want an attachment here. And if I was going to be expanding, I'd probably put one there and probably another one there. Okay? So basically, we're deciding which teeth need expansions, which ones don't. We have a lot of growth ahead of us. This is stage 1. It does not even have a pisiform. The pisiform would be normally right about here, right about like that, okay? And definitely, no, then the sesamoid to be right here. That'd be stage 3. And you can see that the growth plates are smaller in width than is the long bone. Cervical vertebra maturation is also stage 1, flat, flat, flat. Okay, so you have a lot of growth coming. Are we going to do anything about it right now? No. We just recognize it's a growing patient, and it's going to help us in a class 2 type of case. Widths, plus 2.1. Okay. Well, we already saw this one. Skeletal average, we're going to choose, well, get used to it. You're going to be choosing the arch wire to maintain in the automated. You have to do that. It'll start with a medium ovoid. It'll automatically put it on your model. And then you say, yes, that looks good, or no, change it. You can change to another one to maintain. That's going to form the basis for all of our automated simulations, which will be a practical simulation that you could build an appliance on of something that you can expect. No more model measuring, no more 2D VTOs, except for the more complicated cases. Does that sound good? And no more self-tracing. we got an automatic step tracing we're working on. Does that sound good too? Yeah, okay. Yeah, so now you can say you're not going to be spending an hour or two anymore on these diagnoses trying to fill it out. You're gonna do it in about 10 minutes, and you can do it while the patient's in the office. And you can show them what it's going to look like. And I'm going to give you a little taste of that. Okay. Treatment options considered: extraction of fours and non-extraction. No lower E-space shift. These are the features that we ended up with to make the VTO. No lower E-space shift. I did add a growth adjustment. I did add 1 millimeter intrusion of upper incisor. And I left the curve of speed just because I wanted more intrusion of the upper incisor and no IPR. By the way, in these mixed dentition cases, we don't do IPR, and we're not going to be likely doing very much class 2 elastic. That'll be on a case-by-case basis. The reason is I'm going to reserve those for phase 2. Okay? So class 2 elastics possible if growth less than expected in refinement. Okay, in other words, at the next series of tray, we'll think about class 2 elastics, but not the first one. Added growth, and this is where we get if we just straighten the teeth. Okay, is this good? Yeah, I don't know about that. That looks pretty good, but we don't have to have it perfect right now. You see, it's going to be a work in progress. Okay, a work in progress. Okay, well, this one was a treatment decision. Added the growth, no lower molar shift. Treatment decision. Here it was right here. So this looks better. I can go with that. I see a little bit more over jet than I want. Okay, so there will be more or less growth than I factored in, and that will depend on how much class 2 elastics. Okay, now this is a rough 3D result substituting the primary teeth for secondary teeth. This is this case. So you can see right here that we have the primary teeth, okay, and then here we got permanent teeth. Does that help you at all? Visualize where you're going? Exactly right. So that's one of the things that is a feature that we're getting. I'm not getting every feature that I asked for, but this is a feature that we're getting. The mixed dentition is going to come alive for you. It's going to become simple because you can flip back and forth. Let me see all the primary teeth so I can make my appliance, or let me see what it looks like with all the permanent teeth and growth added. I'm going to say that. Okay. All right. So let's see if we can see this. So do you see the substitution there? And then the change from like class 2 to class 1. I'll do that one more time, I think. Okay, you ready? You see some upper molar rotation? Just a little. You see the lower molar sliding forward? Yes. Okay, so this is not related to specific treatment. We're not there at this level, but this gives you, I think, an idea about where I'm going and what you're going to see in a matter of 3 months. 3 months, you're going to see this. Oh, now it works. Okay. Okay, so submission instructions on this case was approximately 20 stages in the first series of trays, refinements to follow as permanent teeth are lost. So this is what you this is what you start out with. The very first thing you tell them how many trays you want, because you don't want them to go all the way to the end. You want approximately 20 stages in the first series of trays, refinements to follow as primary teeth are lost. You get that? This is what's going to set up the case for the future, and the reason why you can keep doing unlimited. You don't say, "Give me 100 trays for the next 5 years." No, give me 20. Then we'll come back. Give me another 20, or maybe 12 if you're going on a retention project, maybe with bubbles, okay? And then you have to give them a starting point. Starting point is upper midline centered. That's their starting point. Synchronize everything else to that. Intrude upper incisor 1 millimeter for leveling, and maintain some curvature speed as needed for endpoint overbite. This is the most important thing. Endpoint overbite. Always specify that if you can. Okay? Correct rotations without collision. You don't have to say that. They do that. And continue until 3-degree overcorrection. Well, I'd probably go 4, but okay. And distal rotation, upper first molars, 5 degrees. That's not very much. 5 degrees is not very much distal rotation on upper molars. Okay? 10 degrees is more. 15 degrees is a lot. But it's okay to make 15-degree distal rotations. It's okay. But they know what to do, to distal rotate around the palatal root. Wait a minute. Is this simulation available with a scanner? This particular one, which is only for consultation purposes, is a MEDIT simulation that they have existing. Ours, we looked at that and said they've already got at least a portion of what we want to do. But you cannot make appliances from that. Okay? The answer is yes. Okay? And you can actually do it right now. It's their ortho simulation app. And then when you see what we do, oh my gosh. Oh, and by the way, that's in Medit Link, which is free. You can all download Medit Link, use any scan from the scanner that you have right now. It should accept it. If it doesn't, let me know, and I will tell you how to do it. And then you can run a simulation. Okay? You just import it. You export from your scanner, import it into Medit Link. The only thing you need on Medit Link is a computer that'll run it. So right now, you need a gaming type computer. It's about, I've got one here. It's about $3,000. That's the high end, but $1,000 does it. But if you have a gaming computer, that's what you need. Okay? All right. The correct rotations without collision. Okay. Upper molar rotation. No IPR. No expansion. Endpoint overjet. 3 millimeters. That in this one I think caused a little problem. Better not to say 3 millimeters. Say 2 millimeters or more. To allow for growth. I think that's important to tell them why you're asking for that. You want a little more overjet because to allow for growth. And then they understand. No attachments on lower canines, first primary molars, horizontal attachments on first molars, and I listed which ones. Gingival bevels on all attachments. The reason why we say gingival bevels is it's easier to remove the tray. And it doesn't make any difference in how well the attachment works or doesn't work. Okay? So here's setup number 1, 19 stages. Remember I said 20. So this is 19 stages. And let's see. So you can see some attachments there for the rotations. And this is the superimposition. The gray is what it started at. The white is the end point. So you can see there's intrusion here. There's incisor advancement. As you can see, the white is going forward from the gray where it previously was. We have our bubbles here for the eruption of the secondary teeth. And then you evaluate this. Is this easy to do? It's a scan, write a few instructions, and you know what? On something like this, you've got more trays coming. You don't need every little last detail in this. You just want to see that they're intruding, they're rotating the molar, but then I gave it to Lala, and Lala went crazy. He adjusted all kinds of teeth. This is a custom adjustment, and he went absolutely crazy. He adjusted every tooth, which that's okay. That's okay, but he didn't have to. But anyway, he changed everything. IPR, added spacing between teeth, changed attachments, that sort of stuff. So that's what was done. And I'm not arguing that it didn't need more. It's just, do you have to go that much detail for your first series in the mixed dentition? Answer, probably not. Okay. But at some point in time, you're going to refine everything. Okay, so here's another. We're gonna watch the setup now. Oh man. Oh, I think it's this. I think it's the. Well, here's another way to see a simulation. Do you see the change in the deep bite? You see the intrusion, upper and lower, the incisor advancement, okay? Now, the primary teeth are not substituting in this. That was my big idea. I just had to get that. I said I wouldn't release software without it. So you can do this in your software. Anti-progressive aligner. You just move the scroll bar across there, and you'll see the teeth move. So the upper incisors are torqued, and they're brought back a little bit. It'd be tempting to say just leave them out there, leave the overjet, but I didn't. Okay, it's fine. We're gonna get another shot. We got 19 trays, and after that we can do it again. So you can see here there's a buccal root torque on the upper molar. So it's in addition to. Oh yeah, here's the overjet. Let's watch the overjet. So you could stop right there, okay, if you wanted more overjet for growth. And then later, maybe some class 2 elastics. Now, are you going to get 100% of what you see? Absolutely not. You'll get somewhere around 70%. In some movements, maybe 50, okay? So again, things that are annoying, like the deep bite, well, do it now. start earlier when everything is less mature. Go ahead and fix some rotations while you're at it, and then later on you can do it again, and then do it again. So in all these mixed cases, you're going to have probably a minimum of three sets of trays. Okay, that would be this would be probably expected, maybe even 4. If you went 4 years, 4 sets of trays. That's what it sounds like to me. 2 years for the eruption, and then maybe at maximum another 2 years, probably only a year. So probably you might get done in like 3 sets of trays. Okay, so this is superimposition number 2 after Dr. Lala got done with it. Now, key tooth. Key tooth is how you really learn what's happening in these setups, okay? And so we already talked about key tooth a little bit with the laterals. Now, in this case, we don't have to worry about the laterals, right? The upper canine's already erupted down the root. So we had on 2.1, we just click on 2.1 in the software, in the progressive aligner software, and then you look on the lower left, you'll see the crown. The crown intrudes 0.6 millimeters. It shows you the torque. Now you'll see here, you're supposed to compare the crown versus the translation, versus the lingual translation. So this goes lingual 0.6, but the root goes even more lingual. So this is lingual root torque, okay? And then, of course, it had an 18-degree rotation. That's going to be corrected in 17 trays. So that would be approximately 1 degree per tray. Okay? And then tooth number 2. That 2.2 is rotated 29 degrees. It has an overcorrection. You see how on this one the distal's out, mesial in. That's probably about a 4-degree rotation, overcorrection. So 29 degrees in 17 trays. That's about 2 degrees per tray. Say, wait a minute, maybe that's too fast. Yeah, that would be too fast for a 30, 40-year-old patient. But this is a young patient. You can go faster, okay? You can have more activation per tray. So they went all the way to fix that. Now, I would have been okay if they left some rotation there and we got it on the next refinement. All right, so we got here and extrusion on this one. So the central incisor intrude. You can see the difference in the gray versus the white, and then on this one, the gray and the white is a sticking down. That's extrusion. Okay. Okay, tooth number 1.6. This is where we were talking about rotating the distal rotation. And I said, give me about a 5-degree distal rotation. Well, 4.9 is close enough, right? 4.9 is close enough. I didn't put that down there because to me it wasn't that significant. Distal angulation of the apex, about almost a millimeter. The root going back into the 7. See, these upper molars are not mesial inclined. So if I put the upper root into the 7 there, and the 8 is also in its way, I don't know if that is going to happen, but it's only a millimeter at the apex. The crown is not going back. There's no distalization. If you wanted to distalize this, seriously, you'd either take out the 7 or the 8 at least, and then you could distalize. But on these young kids, nobody wants to be taking out upper 8s and 7s. So, but I can tell you we have a lot of upper 7 cases, and they work great with the aligners. The aligner is preferred appliance if you're going to distalize. So this is your primary tooth there, and we're expanding. How much are we expanding? We're expanding 0.6 millimeters at the crown, and then at the root apex, we're expanding more. So this has even more at the root, and that's to offset the tipping, okay? So yes, you can do this on the primary teeth. Key tooth 4-1, 15 stages. We're going to correct 15 degrees of like rotation, and that's going to be looks like a full correction anyway, and then looks like it's bodily moving forward labially and intruding a millimeter. Okay, you see that there. How you doing? Okay. You just have to learn how to read these. Once you read them, having this table and being able to read the superimposition, the whole thing, oh my gosh. It makes the whole thing come to life. 17 trays. We're going to do basically 12 degrees rotation. That sounds reasonable. But look at the labial movement of 3 millimeters. See, 3 millimeters in 17 trays. That's a lot per tray. Okay, so that's, again, you can maybe do this on a young patient, but not on an old patient for sure. You can't do that. That's too fast. 0.1 millimeter per tray on an older patient. Okay, 0.1 millimeter. This is more like 0. What is that? 3 or something, 0.3 millimeters, something like that. Okay, key tooth 4-6, so lower molar. And so, see, we've got a little more control of the molars now than if we just put a band on there, okay, but we got a little more like, we can program in different things. Just a rotation on a lower molar. That's interesting, huh? Was it rotated mesially? I don't know. It doesn't look like it to me. Buckle crown torque, though. Let's see. Wait a minute. Crown goes forward 0.8 buckle, but the root only goes forward 0.1. So yeah, buckle crown torque. You're uprighting the tooth laterally. That helps open your bite too, by the way. Okay, and but are we fixing this class 2 mixed dentition look here? No. And also look here about the uprighting, lower molar tip back. How do you do that? Utility arch, right? That's about the only thing you got. The rest of it is just hold it with a lower lingual arch, or if, we do have, in our bands, we do have UP or C2E that'll upright those lower molars. So if you want more lower space, you could choose to, in this case, where is it? Let's see. Mesial trend. So the molar's going forward a little bit. Distal rotation. Okay, distal angulation. Here it is right here. Distal angulation. That would be called mesial root torque or distal crown torque, right? Okay, not much. You can be much more aggressive in a different case. And then, of course, you have your staging. which tells you when to place your attachments, when to do your IPR, when these teeth stop moving. Okay, you can see some of them here have stopped moving on those back molars. They only felt like they needed, less than 19 trays to get it done. Okay, so alternative to phase 1 and 2 brackets would be intrusion. You could do upper and lower utility arch in this case, starting maybe with some 0 and 2 segmental arch forms, molar tip back, molar distal rotation. The molar rotation on the upper would be an upper alignment arch. I would probably do that. Just 18 by 25, 6 to 2 to 2. Growth management, you could bond lower composite, allowing lower E-space. Class 2 elastics is needed in phase 2. Class 2 light change, hopefully, from differential horizontal growth, hopefully. And I did add it to the 2D VTO, but it's just an estimate, a guesstimate, and it may or may not happen, right? Okay, expansion and class 2 elastics, and it'll really come down to how many class 2 elastics do you need at the end. Okay, so that's that case. See how much faster the cases go when we already know what we're talking about? All right, so this one is younger. Now, the gingival display, oh, by the way, any questions on the last case? I just want you to see how you work your way, how you set up the case, and all the concepts that you're gonna do it again. You're gonna go at it with, say, 20 aligners, 25 aligners, and then you're gonna do it again. Okay? No big stress. So, gingival display. Now, gingival display on this, we want to see an upper curve of speed. We want to see the upper incisor, super erupted. But unfortunately, we see anterior and posterior gingival display. And here we have Dr. Hisham's wonderful. I mean, he's one of the only ones that gives me this. And so this shows that I've got room to intrude that upper incisor. But can I do this in the first phase? You might get some impact with a utility arch, but I haven't been impressed with that. So really, if you're going to do this, you need to do it in phase 2. And phase 2 is going to be skeletal anchorage intrusion. So we're not going to do skeletal anchorage on the aligner trays, at least for the moment. I've actually tried a few and I'm not impressed. So we still have things, I've got more ideas, but it hasn't been what I wanted. So no skeletal anchorage. That'll be reserved for phase 2. You don't have to do everything. So let's see if we have super erupted upper incisors. Maybe if I draw an imaginary line, let me see if I can make a real line. If I make a line, as I mentioned, well, maybe we could intrude the upper incisor a couple millimeters, the central incisor. So on this one, you just say level, upper, and lower, okay? And endpoint overjet overbite is going to be what? 2 millimeters, okay? Now, if you want, you could say 1 millimeter, but I don't think you're going to see the difference at 1 millimeter. So you're just going to have to say, phase 2 will decide, if gingival display is important. At the moment, as I recall on this case, the gingival display was not listed as important. And so it's not going to be treated right now. But I would do it anyway if we had a big curve of SPE on the upper. Okay, what we do have, though, is a lack of space for eruption of a upper canine. I can see a bump up here. I can see a bump up here. So that means that the canines are on the lateral. I don't have to use my fingers because I can see it. If I can't see it, you need to use your fingers and see if it was on the labial or palatal. Okay? Do I see a class 1, 2, or 3 posterior? 1, 2, or 3 looks a little bit class 3, doesn't it? Biterminal plane. So then you say, all right, tell you what, I'm going to look on the SEP and see if I see a minus width. All right, we need space, don't we? We need space for the lower canine, upper canine. We need space, right? Now, is that easy to do? Well, with brackets, you could bond some primary teeth. You put some open coils. You could put open coils between 6 and 2. You can push all that forward. And yes, you can do that. Or you just write an instruction and hand them a tray. A little more than that. Okay, so here's our occlusal plane. You can see that the lower is extruded, but do I want to level the lower? No, I want to intrude the upper. I want to leave some curvus B on the lower, okay? If you're working with gingival splay. Okay, and we've got how long until we get full eruption? Well, we got this guy, I'd probably say 2 years here, right? Something around 2 years. We have, this one got a little bit messed up, but we do have like an early pisiform, and I do see a curve here and a curve here. Stage 2. So we got lots of growth still coming. And so this, I have a -2. It's a little skeletal class 3. Oh, perfect. Skeletal class 3. Are you kidding? Yeah, we have skeletal class 3, dental class 3. Wait a minute. Hold on here. Okay. So, so if you have a skeletal and dental class 3, you definitely want to recognize that and say, well, what am I going to do with the growth here, if anything? Okay. So treatment alternatives considered: extraction of pores, skeletal anchorage intrusion, and two-jaw surgery. That would be after full growth to reduce gingival splay. And so in the surgery protocol that we talked about in the last couple of setups, you need to always list that just in case somebody practicing around you would do jaw surgery and they don't know about, the skeletal anchorage intrusion or something. I don't know. So we'll do a phase 1. This one is extract upper and lower force to get rid of that, the protrusion. This one has a 2 millimeter bite change from differential horizontal growth, intrude upper incisor, 2 millimeters, medium ovoid expanded from small ovoid, distalize 1626, and no lower E space shift. Okay, so here's the distalization in the model measuring. Right there. You wouldn't want too much more than that, especially without molar rotation. And then we have the growth, and that's correcting. Hopefully it's all going to end up in the right place. Now, I did some of these cases a long time ago. This was put open coil between the primary molar and the permanent molar that had just erupted and didn't have a 7 there, and I was able to distalize with that. But it's a lot easier to do a that was sectional arch wire. That was the most difficult part, was a sectional arch wire. So I don't do that anymore. The easiest way is an aligner. Just program it in, get them to wear it. Consultation. I think you need to have an agreement. In this case, it was 3 to 4 years, and what extra costs might be included, and that comes down to your style of practice. Remember, we don't do IPR generally in the first phase. We do it in the second phase, and possible skeletal anchorage should be listed just in case you decide you want to do that. And then the submission instructions. Here, you basically, here I said 25 trays, plus or minus, okay? Open spaces to 8 millimeters. Is that easier than packing coil and advancing arch and utility and all that stuff? Yes. Open 7 millimeter spaces, lower canine. That would be an advancing arch. Yeah. Now we're going to do that. Easy. All you got to do is write down what you want. Intrusion of upper incisors 2 millimeters. Now, this one I said, intrude at 1.4 millimeter per tray with occlusal ramps. Okay. Attachments on the primary molars, and I listed that. Endpoint millimeter at the end. Okay. So that would be leaving some curvature beyond the lower, intruding 2 millimeters upper, and so there's an overcorrection of the deep bite. At distal rotation, distalization to a class 1 bite, and 3646 are not allowed to move for mesial during treatment. Okay, so they know, make it here, move those upper molars back to get class 1. Eruption bubbles and expand is also in the instructions. So here's where we get back. So here's your ramps, and she's biting on the ramps here. Here's your bubbles. Here's your class 1 molar. Your class 1 molar with distalization and rotation. Your deep bite's overcorrected. It's 1 millimeters. And this is all done in only 14 stages. I asked this, I said, you go all the way up to 25. They gave it to me in 14. Okay. I go, okay, let's do it, And then, so here's let me see if I can get this going again. Well, yes. Is that a lot to happen in 14 stages? I don't think that's night only. I don't think that's night only. That's going too fast. Okay, so that'd be quite a bit of change per tray. So the other way of thinking about it is do it, get it over with, and then make a long retainer. Okay, that they wear just at night. So here you'd want upper and lower aligner retainers, not retainers, aligner retainers. But don't say that word to them either. Just say, give me 12 aligners, and you'll then instruct the patient to change them once a month or just at night after you do this. Okay. Can you see the molar rotation and distalization on the upper? And then the overjet. Remember, growing patient. Leave a little extra overjet. Don't get it real tight. You can tighten it down in phase 2. Just don't do it right now. So here's our superimposition. So you can see the incisors are advancing. You saw them go forward, upper and lower, right? And in such a case, you could decide that's too protrusive at the start of phase 2, and then decide to extract bicuspids. If you do, then you change the brackets. Okay. So with that in mind, in this, you could probably order a 30 tray package or something, and that allows you two that's only 3 years. So with 2 refinements. Now, just think of them all these mixed dentition cases as unlimited. All right, so again, we get down into specifics. Tooth 1-1, we're intruding. It's going labial. The crown's going labial, 1.3 millimeters, and the root's going lingual. Okay, so it's proclining out. If you don't like that, you could say change the root apex from 1.2 lingual to 0 or something like that, right? Add some labial root torque to it. And then if you give them a specific number, they'll do it every time. Well, I think one they didn't. 15 degree rotation and 13 or 12 trays, that's reasonable. So the speed of that is reasonable. Now let's look at the expansion here. 3 millimeters of expansion in 10 trays. That's like 0.3 millimeters per tray. So if I'm calculating right, I don't know, my mind's tired. So anyway, distal rotation, that's reasonable. So where the 14 trays is this buccal expansion. And if it's too fast, that's where you're going to get loss of tracking. So then this is tooth 1-6. We have quite a bit of expansion here. We have the crown going 2.6 millimeter to the buccal, but the root is going 4 millimeters. So this is the buccal root torque that we saw when we were playing it. And I don't see the mesial inclination to want to tip back the upper molars, but I do see distalization to get to that class 1. Remember, I said the lower is not shifting forward, so 1.3 millimeter distalization, but the root's going back just about the same, and there's no 8. So I think this is fine. Go back and distalize here, and then let the 5 erupt further to the distal, and get the 7 to erupt more of the distal, and you're in great shape. Okay, 4-2. Again, moving labially a long way, 2.3 millimeters in only 12 stages. So, that's pretty aggressive. If it doesn't happen, or if you start to lose tracking, you have the patient wear the tray longer, use chewies, keep it down, instruct them on what it's supposed to look like. Don't change the tray till you get those teeth fitting in the trays perfectly tight, right? And then this one has labial crown torque, so it's tipping forward. Yeah, so you can go that fast when you're tipping. Tooth 4-6, again, you can see the gray to the whatever that is, orange. I don't know, I'm colorblind. And so the lower is actually going back a little bit, distal translation. So the lower is making a little bit of space, a little more arch length. You can see the mesial inclination there. So you tip that back a little bit, you distalize it. I don't see an 8 back here to get in the way. You see, when you got the risk of impaction of lower 7s, that's when you have a 7 and an 8. Okay, the primary tooth, again, this is a lot of expansion. And I remember reading one study a long time ago, if you expand the primary teeth, the secondary teeth will erupt laterally also. Yep. So, alternative to phase 1 and phase 2 brackets is going to be progressive aligners. There are issues with the financing, with the management of those trays, with the management of them coming into the office, but you have that with brackets too. And all you have to do is have to replace about 2 or 3 brackets, and you start getting irritated, GPAs and all that kind of stuff. So it's okay to do that, but these aligners have a lot to be done. And this mixed dentition protocol will grow. And we've already discussed probably an update in 2 to 3 years, and it'll be even more refined. This is the introduction of the mixed dentition progressive aligner protocols. And thanks again to Dr. Hisham, who's been pushing me through this, and we're going to have these cases likely finished when we get to the update. So I can't wait to see how this all works out, and we'll have it well documented. So you can use other appliance. You can use other applications, class 2, class 3, molar management again. But you may have a time where you put an upper molar band and reverse headgear in a class 3 case. That's okay. Or just bond a bracket up there and try to pull it off the bracket. Okay. Or a button. You just have to have something to hold the elastic. Transverse, posterior cross bites, just expand more in the upper than the lower. And keep in mind, you can expand upper, you can constrict lower. It's not going to be the same. It's not going to be the same as a rapid expansion, which is a skeletal expansion, but a whole lot easier on everybody, including you. Most important, that you're not worn out, that you have an easy time in your practice, and everybody has a happy smile on their face. They want to go to work the next day. Thank you very much for hanging in there. And oh, wow, we got done earlier. I thought it was going to be an hour and a half through the cases. It turned out to be an hour. So that's good news. Thank you again for your attention. And I really appreciate the opportunity to work with you. And hopefully you learned something today. And I'll be happy to take questions. Thank you, Dr. Hisham, again for the 100th time. Now you can see why I was pressing you on some of this stuff, right?
yeah, I can. Always, Dr. McGann, always.
He gets irritated with me, I'm sure.
Not at all. I enjoy it. I enjoy working with you a lot. I actually had a question about expansion, and not sometimes when you expand, you don't get the expansion that the software will tell you should get.
No, you're not close. 50 to 70%.
Yes. So do you usually, on the setups, we usually overexpand a little bit?
You overcorrect expansion.
About 50, 70%, yeah.
Well,
okay.
if you want 3 millimeters, you ask for 2. If you want 2, you ask for 3.
And if you want 3, ask for 5, etc.
Yeah, and if you overexpand, well, you'll look at it and you'll say, well, this is getting to be too much here. Let's do a refinement, right? So, but keep in mind, you can constrict, and for every millimeter you can constrict, you have to expand less. So, and also don't forget the little occlusal pads when you're doing that. Otherwise, the occlusion will keep you from having it expand.
Oh, from expanding, yeah. So we have to synchronize upper expansion with lower expansion, right?
Yeah. In your instructions, you'll say an extra millimeter per side on the upper horizontal overjet.
Thank you, Dr. McGann.
Synchronize the upper. Okay, an extra millimeter wider on the upper. Hi, Irving. Okay, he's there. He's half asleep, I think. Okay, Irving.
Hi, Don.
He's been around a long time. Singapore. Okay, good seeing you. I wish I could meet every one of you here and sit there and chat with you about all this stuff. Tracy in there, and oh my gosh. Okay, thank you for all coming and still listening to me.
I think Dr. Haller has a question. He's got the hand up.
Oh, here we go. A raised hand. There we go.
Hello. Hi. Thank you for the wonderful webinar. It has been really great. For the second case, the 9-year-old, he was class 3 skeletal and dental, but the facial profile was convex. Not the typical one, not the typical facial profile for class 3. What would be the impact on the treatment?
Well, you got a lot of jaw growth coming, and in general, you become more concave with growth.
Yeah. Okay.
So don't worry about the little protrusive look on a young kid. Okay, that's going to go away. More on a male than a female, and and you're going to ride the horse through all that. Every year you're going to make another choice.
Okay. Yeah. Okay. Thank you very much.
Don't be afraid of growth. Just make sure that you recognize it, document it, that you recognize it, and you could always say, I did not make any adjustment for growth. I thought the growth would be proportionate. Fine. Who could say that it would be anything different?
Yeah.
Okay. So that's what you need to do is just make sure that you incorporate it into what. So if any third party looks at your stuff, then they're blown away instead of, well, why'd you start this case so early?
Yeah. Okay. Sounds good. Just another question, please. A 10-year-old girl, still, of course, growing, class 2. I haven't done the lateral ceph yet, but clinically, it's really class 2 with massive overjet and not much overbite, but it's a lot of overjet. Can we grow that jaw that much? Like her mom is holding back on the Invisalign because she thinks she will have the option of surgery, or that would work better for her. So do you think I should be I treated few mixed dentition, but not that many. 10-year-old class 2. I feel that we can do I use the MA in Invisalign or elastics. Should I be scared because their mom is really inclined more into jaw surgery, like orthodontic surgery, or should I have very good relationship with the mom. She did Invisalign with me. She's extremely happy with the result. And I did the older sister for the same girl too. Do you think some cases would really have to go for surgery?
Have you done mandibular advancement with Invisalign?
Sorry, say it again.
Have you done any mandibular advancement MA cases with Invisalign?
I'm in the middle of one, and it's doing really well, but I'm still might go back to elastics. I did a couple before. Some worked, the compliance as well is sometimes not that well. But the one
those rings kind of poke into their cheeks.
What's that?
They poke into their cheeks. They're hard to wear. I
know.
I haven't ever worn one myself, but I look at it and I go, oh wow.
Yeah. But for a couple of these people, I put extra buttons to wear at night just to close the wings, because if they open their mouth, it's not going to work. Just to put extra on the premolars, just to close the mouth at night, and it seemed kind of working, but I haven't had one totally finished yet because I started. Yeah.
If it's a skeletal class 2, then that would be a reason for the MA wings or angel line twin block. If it's a skeletal class 2, cervical headgear, maybe like a twin block now. Just a regular twin block, something to hold the mandible forward. You don't necessarily have to have an aligner to do that. And then the concept is you can do a certain amount of a little here, a little there, a millimeter extra advancement of the mandible, some growth management to try to get the most that you can. Maybe some cervical headgear, hold back the upper. Maybe some like dental distalization, and if you add up, and maybe some IPR. When you add it all up, you may not need surgery. Okay, but if all else fails, they'll get a chance when she's about. You said it was a she.
She, yeah.
About 18 years old or so to decide on jaw surgery. And all that stuff is not going to hurt the ability to do jaw surgery. So you can do jaw surgery then if you don't like the end result of the other alternatives, because we don't know how well she's going to wear some of these appliances that are removable, including cervical headgear, MA appliances, all that kind of stuff. We don't know. So the preliminary diagnosis would be this. Secondary diagnosis, start of phase 2, maybe consider extraction of upper pores, or maybe set it up for surgery, pending, the end of her growth.
Yeah.
Skeletal anchorage works, Don.
Is what?
Skeletal anchorage works, with Nate, my son.
Skeletal anchorage? Like on your son?
That works.
It worked. It worked. It didn't. I think I made one mistake on that, and I paid, but it was doing real good until that. I just didn't. We ended up with that. We were trying to get the vertical more, and it backfired on us. So, but then but it still came out looking good. But there for a while, it was fantastic. And then we kind of lost some of it. I apologize for that. So, anyway.
Worked out well.
Yeah. Oh, no. I mean, skeletal anchorage is an alternative to jaw surgery. For sure.
Thank you very much.
Sitting here talking over an iPhone, that's not really, diagnostic. But anyway. It takes a lot of thought trying to figure it out, and then set up the thought process, right? In other words, we'll go here, we'll take the first checkpoint, and then we'll look at it again, and make a plan so that you're not, maybe you don't have to do jaw surgery. Maybe you do all that, and you still need jaw surgery. Okay, so.
Yep, that's fair enough. Yeah, thank you for reassuring me.
You're welcome. Any other questions? Comments? Stories? Okay, well.
I actually did have a question, Dr. McGann, about that software that you were showing that showed what the final could look like at a kid. Is that going to come with the feature of the diagnosing? Like you can say, all right, I'm going to do the twin block or the occlusal block or whatever it is, and then in the end, it's going to give me a diagnostic tool, and
Okay. All right. So let me just those of you that stayed late, you're gonna get a secret. Okay. Let's say that you took one of those cases, and after identifying each of the teeth, rotations, the starting position of the teeth, and you hit. I want the simulations for class 2. This is a class 2 case or a class 3 case, whatever. I want the simulations that apply. You'll see 8 or 9 different simulations related to the actual treatment of those cases and me defining where the teeth would end up. I programmed my whole mind into that. And so you'll have a choice of 8 or 9 simulations. You'll then overlay the Ceph on them so you can see some of them, my teeth will go out of the bone. So you'll say like decline, 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 decline. Oh no, I like that one. Boom. Okay, I got it. And it might be expand with IPR, might be expand with IPR and distalization. That'd be another one. Might be, I don't know. It'll be ever growing, right? I will make more simulations. Right now I have 40 simulations. I have simulations for 40 different treatments.
Wow. And will that include the movement from mixed to permanent dentition as well?
Yes.
Oh, that's exciting.
And it'll also include brackets. So if you want to choose brackets, like it's a bicuspid extraction case, hit the button and it will choose all the torques and rotation brackets, and you send it.
Wow.
Or you just go right to ordering, or you go right to ordering the aligner trays, no technician.
We don't even need to be there anymore. We can just go home and sleep. Technician and the patient can just talk to each other.
Well, we'll see. It better work. But I had, let's put it this way, 1,000 PowerPoint slides on how to program it.
The time
Every
that
detail,
when you're retired doesn't sound like you're very retired, Dr. McGann.
No, I've done it. I did it years ago. Okay. So that's probably been, I don't know. It's been about a 5-year project, but I don't know when I wrote the simulations. Right now, I'm going to have to go back and refresh my memory. But they are doing simulations right now. They just won't show it to us. They are doing auto tray Cephs. We're seeing some of those, and I'm correcting them. It is choosing rotations. I'm seeing some of those. We do have attachments. We're refining those. It's happening. That's right. That's right. I'll put myself out of business on the consulting, right? Well, it's going to fit a certain number of cases. It's not going to be every case. So some cases at the update or at the product release, this could be called, and Miles is already scheduling the Australia ones, but I'm not doing them. I'm only doing one. That's the one in California. That one will not be videotaped either. So he's going to, so I'm going to present it first, and then He's lining up worldwide locations and instructors that are going to teach that. 2 days. Don't miss it. You miss it. But anyway, part of it's going to be what doesn't work, right? Here, this works. Isn't this cool? You just saved yourself 2 hours, And not only that, you can, well, we're working right now, we're working on, it's called like digital ortho, right? And we're working on the workflow. So
this all sounds super exciting. I don't think I'm going to miss that.
Yeah, the workflow is, the workflow is possibly even starting right away, getting agreement right now while the patient's getting their teeth cleaned. And schedule them back. Please bring the staff so I can confirm it. And 100%.
I'll be on phone calls this week. I'll make sure we're going to get all the SEFs, all the update scans for every case. All the data you need.
And we'll have the trays waiting for you.
Dr. McGann, cheers.
Well, it's kind of like, okay, when I first started, everything was quite simple in POS. And if Fawaz would be able to tell you this, everything was quite simple. And then as I got more and more, widened the scope of everything and the efficiency and the things that we could do, it became more complicated. Now it's going back to like hit the button and order it, put it on. So, and that changes everything. But that's what we do. If we see a better way of doing it, then we're doing it. And my son Miles was one of the original idea makers on this, and then I took it from there and did the technical part. But I couldn't have done it without him. There's a whole lot of business going on to make all this happen. Just like with the aligners, that's just one part of it. It's a necessary part of what we needed. And I'm sorry over there in Australia and Singapore and stuff like that is sort of stalled out. But I'm sitting here making the education and the teaching you guys. So when it's there, it's ready to go. But Fawaz has been using it already. So and it's very good. So, and not only that, it's how to use it. And our finishing aligners and all that kind of stuff. Now we've got the capabilities to do amazing things. And then we're going to put it in your hands starting in January.
I still have had to do, how many cases have we done now? Well over 50. And I've still had to spend 2 hours for every case.
I know. I spend 2 hours on every case, right? Right? So every case getting 4 hours of doctor time. I mean, no wonder they're coming out good.
Yeah. My life's easy after that.
Yeah. Well, but you see, the orthodontist doesn't do that. They just go look in the mouth. That'll be $5,000. Put them on. And by the way, the orthodontist does not want the 3 to 5 year case. That's our case. That's our case. That's ours. The orthodontist doesn't want that. They'll just say wait until the teeth come in. Okay. So no, I'm having you're having more impact on the field of orthodontics than you realize. If it wasn't for you, how am I supposed to do all this? If you weren't providing all those updated records, and we didn't see updated records as this, but there will be someday, And I have hundreds of cases in PowerPoint.
Good sample size, a very good sample size.
Very good. And when it comes down to choosing cases, I have a lot of choices. No, in other words, and they won't be the best ones, they'll be the most educational. So that's just what I do. And that's what I've been doing. I don't know, this keeps dragging me on to like retirement number 2. I don't know when that'll be.
I don't think you're capable of retiring. Just give up.
Well, I enjoy it too much, though, too. So, I know I already did retire, for 6 years.
Like, what did you do? More ortho?
No, nothing.
No case diagnosis?
Nope.
I'm suspicious.
Nope. Then I came back, and look what happened. I came back to learn aligners.
Here we are.
So that's what I did. But anyway, you give me a bunch of mixed dentition cases like you did, and look what came out. Because I study them. I study them and I think through them, and I wake up in the middle of the night and I go, "Oh my God, we should be doing this."
I'm not surprised. Not surprised at all.
I don't know. It's just who I am. It's just who I am and what I am, I guess. I don't know. But anyway, it's nice to be able to see. I get paid the same whether or not I do anything or not. I don't have to do any of it.
That's the definition of a passion, isn't it?
Yeah. So I do it because I want to do it. But I can't. I have to say, sometimes those cases you send me, there's some tough ones in there, and that's a harder day for me.
But you love it. Come on, please.
Oh, no, I do. I do, especially when I get through with them and I go, okay, I'm glad he sent me that one. Who else is going to do that, So,
yes.
Anyway, it's been very rewarding for me, and it continues to be. So, and I had a passion years ago, right for was. When I was in San Jose there, and we went out to the Indian restaurant next door. And wasn't that you that we did that?
With myself? No.
No, who was?
Yep. Yes.
Yeah. And we went.
I've been doing it for 20 years, and at that time, I think you were already teaching for 30.
Yeah, I know. Yeah. I don't look that old, right?
No.
You don't look a day over 85. Not a day over 85, Dr. Pickett.
I still got a smile on my face. I got a cane, but that was from a big fish that I didn't catch. It was a big tuna, I didn't catch it. And then a suitcase that didn't roll. And I twisted my back and had a cane ever since. So, oh well. But now I just lost some weight and I can walk without the cane for quite a bit. So,
All right, good.
But other than that, I'm still going. They're gonna, this ortho isn't gonna kill me, right, Terry? You've been around forever. You were back in the original Australia classes, right? Terry,
I've been around for. Can you hear me?
Yeah.
Good. Yeah, I've been around for a long time with you. One of your keen followers for years, Don. I've kind of ventured off into a lot of other worlds, so like lasers and things like that as well. So yeah, so you still inspire me. I think my brain's wired to think the way yours is. Yours does.
Well, okay. Inspiring is a wonderful word, and thank you for that, because I want people to do the absolute best to get the most out of their profession. and to do the best for their patients. And if you do that, guess what? Everything else falls in place. So, and I think you've done that. So nice going, Jerry.
Thanks. I might send you some tough cases or interesting things sometimes if you're interested.
Yeah.
All good.
Well, I can't take any more than what I'm doing.
Okay, anyway.
Wait till this project is all over.
All good. Anyway.
Is that a hint for me to stop sending you cases, Dr. McGann?
Even after January 20th, I've already got an assignment. I got to refine or do more, simulations. So there'll be a lot to do for the next few years. And starting in about 2 months, oh my God, the first week in December, I already know the shit's going to hit the fan. I'm already planning on nonstop. I don't know what I'm going to do with the case diagnosis and stuff because it may be too much, but I don't know. I'm hoping that these guys are very good programmers. So we'll see. I don't know, but I can tell you it probably already works, or I would have already heard it. This doesn't work. What are we doing over here? Cancel this project. See, I didn't hear that. So I know it works. It was all in my head. Big imagination.
Yeah.
Okay. Well, thank you everybody for attending.